Virginia Cardiac Surgery Quality Improvement Group. So I'm excited about it.
Glad to have you. Amy, can I call upon you, my dear? Amy.
Unmute.
We'll come back around. I'm not going to forget you. Diane, can you tell us about yourself?
Hi, I'm Diane Alejo, and I'm actually with the Maryland Cardiac Surgery Quality Initiative. And we are organizing a perfusion group in Maryland. And I have worked with Eddie for many years as co-founder of Vcsqi. And so although I'm not a perfusionist, my background is really doing informatics and research in cardiac surgery. So I'm just hoping we can collaborate some of our initiatives with Virginia and learn from each other.
Thank you. Glad to have you here.
Thank you.
Dr. Kern, I know you're going to leave and you're a visitor, but you want to introduce yourself? Have him on mute too. We'll come back. Miss Judy Smith, would you like to introduce yourself, please? Okay, we're muted as well. Leslie? I'll go back to Judy. Judy, I see you're unmuted. You want to tell us?
Okay, I'm sorry. I'm unmuted. I'm here as a visitor. I'm a visitor also, and just want to see what Eve was up to. And, you know, perfusion is such a big part of the database, and I'm just interested in learning and hearing what you all are up to.
Excellent. Thank you so much. Maggie.
Hi, this is Maggie Crawley. I'm from VCU. I'm one of the data managers there, and I'm also visiting just like Judy, so interested to hear. Thank you.
Thank you. Mike?
That's you.
Well, coming on camera. Hi, Mike Gelvin. I'm the Director of Perfusion here at UVA, and just really excited that we can form a coalition that, you know, kind of takes some cues from other parts of the country that are doing similar things. And, you know, as their systems have grown, they've been able to show, you know, improvements in outcomes, and hoping we can replicate that in our area.
We'll go back to Amy. Amy, you're muted as well. I don't know if you want to introduce yourself to the group. And Dr. Kern is here as well. He wanted to pop in and support. Nice to see you, Maggie. All right, Eve, I'll toss it back to you. That is all that are checked in right now.
All right. Thank you so much. So happy that all of you are here, and hope you can stick around till we get done. I did ask Sherry and Eddie to pop up some slides here and give us some idea, as you've probably been reading while the others are introducing themselves, about the amount of influence that we can have over the cardiac surgery that's done here in the Commonwealth. It looks like to me, Sherry, if I'm right, about 94% of isolated CABGs and valve procedures fall under the institutions that are members of the Vcsqi. So that's a, you know, no need to really go any further than that. If we reach a point where we can begin to study our practices and come up with some consensus, or come up with some change that we think is going to be the best interest of our patients, we're going to be affecting a huge minority or majority of the cases here in Virginia. So we can go to the next slide. Share. I hope you'll all agree that that makes our effort here kind of worthwhile. These next couple of slides, Sherry, you can go into a little bit further, but again, this is the kind of, and again, it looks like everybody on this list is fully familiar with Vcsqi. I expect that at some point down the line, we're going to have some participants or some members who are not fully aware of what you all do. So, but I'm glad to see that you included these slides, and Sherry, you can go into and talk about them a little bit as indicative of the kind of product that we can get.
Mm-hmm. Sounds good. Sounds good. So this is an average, you know, our standard slide that of one of our quality metrics that we try to measure and report out on a quarterly basis. So this slide specifically here shows us the impact of the blood usage for intra-op blood, and that's any blood product for first and second quarter of 2020. Yeah, that's the year we're in. So we blinded each facility. If you're not familiar with what number your institution is, feel free to shoot me a message and I can let you know. We will definitely share these slides with all of you as well. And this will be talked about as well in the full quarterly meeting. But this is just the impact, the blood use throughout all members of Vcsqi. Pictured here is 16 different facilities. There is one facility who has not yet updated their data, and we didn't want to skew the numbers any way by adding that. But this is just a snapshot at a high level of the impact of blood use for intra-op.
If I could just interrupt for 1 second, Sherry, thank you for pointing out the indicators down, or the identifiers down at the bottom of the slide, and just a point of reference, that is the advantage to using this platform that already exists, is that we can blind our input from our practices so that we can respond, in a way that makes us, comfortable with reporting accurately and getting the real data forward. You can't always do that if you don't have the right platform. You can't blind it. So we're fortunate that Sherry and Eddie have offered us this platform and allow us to do that and continue to produce products like this with blinded results.
And then the same type of layout, but right now we're looking at post-op blood products for the first and second quarter of this year. Same, our centers are blinded. This is the impact. So you can see in the background, there's like a little bit of coloring. We have also grouped our centers by the volume of cases. So the low volume centers are pretty much centers that have less than 150 cases. Our medium volumes typically have 150 to 300, and our high volumes are greater than 300 cases. Okay, so I'll pass this back over to Eve.
All right, thanks, Sherry. So I hope that will inspire you as to what kind of result we can look at. And Sherry is a whiz at producing that kind of graphic. This is the pitch. So all of the red colored institutions are on board and have responded to us in one way or another. And the ones that are in gray, we just haven't been able to reach out to yet. My question for all of you that are on the call today is, do you know anybody that works at any of these institutions? Are you willing to reach out to them? It's entirely possible that these folks don't have data managers that that communicate with them about the Vcsqi, or they're just unaware of the institution, and we haven't been able to reach out to them yet. So if you know somebody at Virginia Beach, Rockingham, Norfolk General, Memorial Regional, Lewis Gale, or Levinson, and are willing to help us, then reach out to me or reach out to Sherry, and we'll start figuring out a way to get a hold of these people, send them some emails. The goal, of course, is to get to 100% participation from all of the 17 member institutions. It'll still be a small group, but we'll have a lot of power if we can make that happen. Okay, Sherry, next slide. We are going to talk about that first survey that we put out. We were really pleased with the responses. 8 responses is good. For the previous slide, you saw how many we had that were interested in the program. So We're excited about that. Here's how you answered. What is your current staffing or equipment readiness for TAVR procedures? Interestingly, as you'll see on the next slide, we had a lot of written in comments, which we're happy to have, because it let us know that we missed the mark a little bit, and that folks, for the most part, don't prime their pumps prior to the TAVR procedure. They take a dry pump in, and then if you'll go back, Sherry, if you don't mind. And it looks like the majority, 5 out of the respondents, have a perfusionist in the cath lab for the duration of the TAVR, and then 2 practices had someone there only for the deployment of the valve. Is there anybody willing to speak up or say anything about the results here, or interested in the results? Any discussion at all?
This is a stupid question.
Yeah, I just want to say, this is Kern. I think, this is good to get at, to see how we can standardize in a safe fashion, but obviously a cost-effective sort of fashion. And I don't know, beyond what you're trying to get at here, I don't know anything else out there that looks at this, but it would certainly be good to know and to have, so we can all feel comfortable, that we're doing the right thing. Because I don't necessarily know that the way we're doing it at UVA is the most cost effective, but obviously patient safety is priority. So there's probably room to make some improvements here. So congratulations on looking at this.
Someone else was going to say something. I'm sorry, I couldn't see who it was.
Judy, and it's a totally stupid question, but how long does it take you, if you've got a dry pump in the room, how long does it take to prime the pump if, say, something happened, something blew up?
Yeah, obviously that's the question, right, Judy? And, it would depend on the state of the pump when you get it in there. You have it ready to drop volume in and make the thing start going around in a circle. It might not take you, but I don't know, maybe 5-6 minutes to get it ready to go. But again, it just depends. And then you'll see as we go along a little bit further with the slides, that's going to vary as well, because some folks are using a full bypass pump in the room, and then others are using other systems like an ECMO pump. So yeah, but that is the question, and I'm interested in that as well, Judy. I'd like to know that too. And so the next slide, we're talking about do you alter your state of readiness based on any particular parameter, i.e. patient criteria. You've determined that there's an issue with your patient that renders that patient to be particularly high risk. Procedural indicators being an alternate catheter access, such as a carotid access. We find those to be indicative of needing kind of a higher level of attention here. And a physician request, or what seems to be the majority of responses where if we don't alter at all, we go in the room and we stay, as seen in the previous slide, we stay in for the whole procedure, so we don't alter it at all. Any comments or discussion about that at all? Based on the responses to this and just kind of following through, can anybody see the need or that it would be advantageous to have a kind of a set list of reasons why they might rank a particular TAVR higher risk or lower risk? Just a question. Hi, Sherry. Next slide. Thank you. And so this was the last question that we asked. You know, what kind of equipment are you using? What are you putting in the room? And as you can see, the majority of folks are using the full bypass pump. I'll just go ahead and start my own discussion here. I think the thing that I was interested in talking about, if anybody were available, is has there been a change? The folks that put the ECMO pump or the left heart bypass in the room, were they at one point putting in a full pump and they've changed now and they use the ECMO circuit, or vice versa? So I would be interested if I could get the group all together. That's kind of what I would ask. Does anybody else have a question or a point that they'd like to bring up about that?
Yeah, this is Mike. So I think it's interesting that you had 8 responses, but you have 10 here. So it looks like either some places are using a combination of different things based on surgeon preferences or acuity or something like that, or like you said, they started off with one and it morphed into another system. So, and if they have, it'd be curious to know why the change, what advantages they found in changing from one system to another.
Yeah. I mean, I don't.
You know,
yeah, please go ahead.
it's something that I think would be interesting, and I don't know if Eddie or Sherry could get this out of the database, but I'm just, because you know, you asked the question like, because my question is who's going to convert to an open, right? And I'm thinking, because I get to see them in the adult cardiac surgery database. They had their TAVR, something happened, and then they have to come for an open ABR. But it would be really interesting to see how many conversions that you really have, because if nobody, you know, but you don't want to have that one person, like you're not ready for that one person, like it seems worth it to do it for everybody. Maybe, I'm not sure. It's like Dr. Kern says, a huge amount of resources, but I wonder if there's any way out of the database we could see people that had, I think it's actually in the indication, Sherry, like why people had to have their emergent ABR, because it is emergent. That might be interesting to see.
Let's see if we can pull it. I'll pull the wise one, it's Eddie. Let's see what we can find.
So we went through this. I'm sorry.
Mm-hmm.
We went through this in a similar fashion over the last couple of years, and Judy may not have been intimately involved with these discussions, but same thing as it related to kind of high risk laser lead removal and extractions. And you know, as the EP folks started doing them, you know, sort of like everyone was quote high risk. That's they're called high risk. But then we stratified after doing it for a while and realizing, you know, we don't need, you know, an entire OR staff and perfusionists and pump and everyone there. So then we kind of found a way to kind of stratify the high risks. And, you know, I'm just sitting here thinking about this. I mean, I'm sure some centers are probably, their routine TAVR patients probably more high risk than other centers. But there's got to be a way, and Judy, you were getting at that we can probably figure out a way to safely stratify those folks in whom it makes sense to have more resources more immediately available versus not.
Yeah, thank you for that, Dr. Kern. We are looking into that a little bit, and we are curious about it as well. And Judy, I do have a list, a cohort of patients here at UVA who have converted. I don't know. I mean, one of the, you know, that's why we're here. That's why we're trying to develop this subgroup, is to see if we can't widen that data cohort a little bit. And so, Sherry, I'm interested to know if you can pull up anything. And likewise, I mean, if the perfusion work group thinks that this is valuable for us to continue to research and dig in a little bit deeper. These were just kind of an opening salvo to see what kind of response we got, and we got really an impressive amount of response. And so hopefully we can move forward and continue to look at it and maybe create some statewide data. Sherry?
Sounds good. Yeah, definitely will look forward. I will keep you posted.
Thank you. Let's see, where are we? These were just a couple other written comments, and I did want to say, when we put a survey out, we will try as our best to put in text lines so that you all may make comments, because that really does kind of drive us to the point of understanding when we hit the mark and when we don't hit the mark. And so thank you so much for taking the time. I know that takes a little extra time, and I appreciate everybody that went to the effort to fill in the comment sections and tell us a little bit more, go a little bit deeper. Okay. Sherry, these are your slides as well. They're super interesting, and I'm looking forward to you telling us what you were looking at here.
Actually, Eddie had pulled these. I'll speak to them, but I may not speak to them as eloquently as Eddie does. But he queried his system, and he found a couple of fascinating data points, actually, that related to perfusion surrounding COVID-19. Of course, this is something that affects everyone and everywhere. But this was some interesting charts that he found. So as you can see, look at the big dip. COVID hit, sometime between closer to the second quarter. So look at the huge dip and what the impact made from COVID. So this is something pretty much interesting. He noted that it was a 27% drop in cabbage cases for quarter 2 in 2020. The blue line is for all isolated cabbages, and the purple line is for emergent operations. So he just wanted to point that out for us because it's pretty interesting. I'll give you a moment to take it all in. The next slide he prepared also dove in deeper to intra-op blood transfusions by quarter, first quarter 2018 and through second quarter 2019. But as you can see, there was a slight dip in quarter 1 of 2020, but then started to increase again through second quarter. And around second quarter, of course, that's when COVID really took the toll and there was shutdowns, but it seems like there was more intra-op blood transfusions during that quarter.
Sherry, it seems to me, just abstracting the database, like the patients that came in that second quarter were so sick. I mean, I don't know, you know what I mean? They seemed to be complicated. They seemed they weighed, I don't know. Yeah. Like, I don't really, they just seemed a lot sicker. We also had, I don't think there was as much blood supply around. So there was, that also is going to play into this. The longer COVID goes on, I don't think people are giving blood.
Yeah, that's a good point. I think you're absolutely right. We're going to talk more about COVID at the quarterly meeting and the impact it's having on us all. Yeah, at this point, the highest intra-op viral rate since STS. Oh yeah, he didn't point that out. So we're taking a look at post-op blood transfusions. So along the same timeline. There was a dip and then it came back up. Made a note, yes. The highest post-op transfusion rates since 2013. Very interesting. Okay, and before we dive in that, do you have any questions, anything you wanted to reflect on or comment about as it relates to the data that Eddie pulled out of the system and just the impact overall? Before we dive into the polling question, is there a question or any conversation you wanted to, or any reflections on this you wanted to mention?
No, I just, I guess I'm sitting here wondering if anybody else is surprised or taken aback, or whether this was expected, the actual numbers.
I'm not really surprised, Eve, with the patients that came through that second quarter. It makes sense to me. I'm just glad we had the blood to give it to them if they needed. And this is anything, right? So this is FFP, platelets, cryo. This is anything, right? So.
I agree with Judy. I mean, for a few weeks, the only cases we were doing were emergent cases. So the percentage of those cases that actually got blood were probably higher than, you know, the elective cases that come in.
Okay, so let's dive into a little survey. Well, let's make it a little interactive. If you're looking at your screen, there should be a bar across the bottom or across the top, and there's a button with a pencil, and it says annotate. If you click on that, you have a couple of different options: a check mark, you can draw, you can write text. So if you can take that stamp, actually, which is a check mark, and use that tool to answer this question. And you can pick a heart, X, whatever you prefer to choose with the annotation tool. But use those symbols to kind of put your stamp on which area is of interest to you. We have so many opportunities within this group that we can start. I'm sorry, that's the ice machine, if you can hear that. There's a lot of opportunities that we can start and dive into, but we're looking to see what's the most valuable start for the group. So select up to 4 different factors, assets, subject matters, and to help us to see what the importance is for you or the value. Where should we start? So if each person can select 4, what that's going to show us is where the collective, where the collaboration, where everyone sees most benefit. So AKI, post-cardiac surgery, staffing, professional meetings, stewardship of available funding. But case selection.
Where's the tool?
If you look at the bar, there's a bar that says mute, show your video, and then there's a option that says annotate. Right next to, it should be right next to the chat button for you. Do you see the Zoom bar?
Yeah, we don't see an annotate button though.
Let's see. On your
You have to look at the top where it says view options and bring the bar down and it'll say annotate. You have to click it.
Gotcha.
Thank you. So much power within Vcsqi, even to find the annotate button. Thank you. Oh, my computer went off the screen. Everyone get a chance to fill in their score?
Yep, we did hear.
Okay. So this Eve gives us let me take a screenshot, just in case I don't want to lose this. No! They went away.
It went away?
Yes. My computer did something weird.
Go back to the, can you go back to the slide?
Yeah.
We'll see if we can agree. I think I saw the top 4.
Yeah. What was the top 4? Do you recall?
No, I have to go back to the slide.
Yeah. Can you see it?
Nope.
I have it. Technology and COVID.
There we go. So it's definitely AKI. It was Del Nido usage. It was quality metrics for individual perfusionist performance and goal-directed perfusion. Right?
Yeah. Goal-directed.
Does everybody agree it looked like those were the top 4?
Yes, it was.
Thank you very much. I appreciate your participation in this.
Yeah, thank you, Sherry. That was fun to get everybody involved right away. The intention is to make this the next survey that comes out. So we'll continue to get the input from those folks who couldn't join us today, and to weight those topics as those that you all are most interested in studying and talking about and starting to develop. We won't do them all for at the same time, but hopefully this will help us to guide us to those areas that we want to study, and then we can put our data collection together, you know, and draw lines from what we're seeing in our practices, draw the line directly to the rest of the VCI big body group, and help them to kind of flesh out some areas of cardiac surgery practice that aren't normally looked at, because our practice is so frequently kind of overlooked or misunderstood. So again, I just want to say, Sherry, thank you so much for putting the slides together and making us a fun poll and all that you're doing. And I do hope that if you know somebody, please, if you know somebody that you can be in contact with, or a friend of a friend, or somebody you used to work with in another practice, please just help us spread the word and put them in touch with me or with Sherry. Sherry, was my email? I don't think my email was on any of those, but we can put it out. Sherry can put it out for us. And I'm happy to talk directly to them if they, you know, or have some misgivings or misunderstandings about what our vision is here. I'm happy to speak to them, or, you know, email with them and try to make everybody feel comfortable. We want this to be a place where you can trust that your data is going to be used in the right way, and, you know, without any judgment. Also, Sherry, while I have you on the line, can I ask you this? Can we do like a group email so we can converse with each other? Can you set that up through your?
Sure will.
Okay.
I'll send you all the slides. I will add you all to the distribution list. If you want me to remove you, please let me know. But I will take care of that, and I'll send it to you before, tonight is going to be a long night, but I will send it to you before the end of the week, definitely.
Awesome. Thank you, Sherry. And I did want to reach out to those of you that aren't perfusionists and stayed on the call with us. Really appreciate your input, and hope to, you know, again, help you to put some thoughts together that you might not otherwise have without the perfusion input. So thank you for that.
Sounds good. Does anyone have any questions or comments? And before we go, let's ask a few questions just to see where you are as it relates to perfusion. You know, integration of perfusion into your electronic medical records. What electronic medical record system are you using? So let's go down the line. Adam, what are you using in your institution?
We paper chart currently, but the hospital uses Cerner, but we're switching to Epic, and with the Epic switch, we will, well, perfusion will be on an electronic medical record. So that'll be at the end of next year.
Pretty cool, pretty cool. Amy?
Hello, this is Amy again from Inova. We use a Spectrum Viper for charting.
Excellent, thank you. Diane, what are you using in Maryland? Well, I know you're not a perfusionist. You know, have a...
Yeah, so so we have Epic, and our perfusionists document in the anesthesia section of Epic. So when we went live with Epic, we made sure we were paper-based prior to that, and we made sure all perfusion documentation went into the anesthesia module. And we actually extract a lot of data out of Epic from the Clarity database. And we're now evaluating the Spectra Viper system. Our new pediatric heart surgeon wants this, and so we're looking at adding that as a next step.
Good, thank you. Dr. Kern.
Yes, I'm here.
Yes.
Are you asking what EMR we're using?
Yeah.
Epic.
And perfusion here at UVA, we use Connect.
I may have missed it. How do those interface?
Dr. Kern, that's the data pad that we have on our pump that we put our record into, and it interconnects with Epic.
Okay.
Yeah.
I was overlapping and just finishing a meeting with you know, like everyone, we're trying to enhance our telemedicine capabilities, and so was just sort of finishing up that meeting with the Epic people and trying to get a handle on their timeline of when they'll have that available. So sorry about that.
And I'm sorry if I may have missed something. Leslie, was your institution already represented? And Diane is from Johns Hopkins. Thank you, Diane. Maggie, was your institution already represented?
Yeah, Adam answered for us at VCU.
Thank you very much. And Judy was already represented, and Mike was already represented. Okay.
Yep.
Excellent. The next question, and we spoke about that. How does it integrate with Epic or other systems? What changes would you like to see? So based on what you're using right now, is it functioning very well? Or if not, what changes would help from your perspective?
So this is Diane Alejo from Johns Hopkins. I can speak because I have recently been working with our perfusionist, and we have a couple documentation issues because of the way Epic is configured, because of the roles. So our anesthesiologists log in with one role and our perfusionist log in with another, and they can't out of the box necessarily see what each other are documenting in some of the flow sheets. So we had to reconfigure Epic and had to do some retraining to the anesthesiology residents. So that was kind of one of the things that would have been nice to do from the get-go, because we realized because they're documenting different things and not seeing different perfusion data elements, that we needed to change that. And then second, we're actually extracting data out of Epic through Clarity and putting it in sort of a staging database, connecting it with our STS data and building some Tableau dashboards so that we can start looking at some of the intraoperative measures. And so what we would like to see is to be able to expand that and come up with sort of a perfusion dashboard for monitoring. We're always 2 days behind in reporting it on Tableau because we have an extract that goes from the Chronicles database to the Clarity database, but that's one thing that we want to do.
Thank you.
Diane, are your perfusionists, you said you were at Johns Hopkins, is that right? Are your perfusionists using the Spectrum system?
No, we actually have a new pediatric cardiac surgeon that joined us, And we're now evaluating that system for the pediatric program as well as the adult. But we don't have it. It's really interesting you asked that, because our Epic team, they're really not sold on the additional cost because we've already integrated a lot of perfusion documentation in Epic. But it doesn't capture, you know, the detail, the minutia, you know, that Spectra does. So we're actually working with the vendor and getting them in and evaluating it.
Okay, thank you.
Mm-hmm.
Yeah, there's a fundamental problem about whether you use Epic or a third-party system to document, in that most, I mean, without a lot of workarounds, most heart-lung machines and associated perfusion equipment does not communicate directly with Epic. So if you use Epic, at least as of a year or two ago, it required you to have a laptop near you where you were typing in all the information while you're on pump. But the positive of that was it was directly in Epic data. The system we have is, it talks directly to all our machinery. So every 20 seconds, we're capturing data from all incoming sources, including the anesthesia machine for vitals, including our pump flows and temperature control and stuff like that. The negative of that, though, is it doesn't necessarily go straight into Epic. We end up having to import a file, which then gets sent to the media tab. So when someone like Judy's looking for cross cleanup times, she goes and looks in the media file for this chart and then pulls it up that way. So I think the big ask would be if Epic would either open their doors to the other manufacturers so we can port directly, or they would actually develop a well-founded perfusion module, and so places like Hopkins or whatever don't have to do their best to reconform an anesthesia module so that it captures what it can from perfusion but doesn't get everything.
Yeah, Mike, that's a good point. And so all of we don't have a system where it goes into the media tab. It's all discrete data, and that's how they expanded the anesthesia module. So perfusion are really documenting in the anesthesia module, and that is really a big win for us, because we can export that data and do research and quality monitoring of that outside of Epic. We haven't built any dashboards in Epic to look at the data. We're doing it in Tableau.
I guess the downside, the reason we went with the other system is the downside of that, at least at the time, maybe it changes. It's dependent on your perfusionists spending their time manually entering on a computer or a laptop while they're on bypass, versus ours. We spend almost no time doing that, so that our focus is on the actual pump itself and what's happening. And the only thing we're entering right now is blood gas information, but we're trying to work with Siemens so that automatically imports as well. So our need to actually physically import stuff is almost zero, with the idea that allows perfusionists to be more ready for emergency type situations or not distracted. However, when it comes to data mining, it makes it more difficult.
Yeah, and we extract data, some of like the pump times and the OR times and anesthesia times, and we import that into our STS record. So it kind of has been beneficial from an STS registry perspective as well.
Yeah.
If anybody needed information, I could get you in contact with Chad is our perfusionist. You know, I don't know all the clinical details of that, but we would be happy to share with you how we document and what we're doing, if anyone wanted to reach out. I know Chad was very instrumental in setting up the anesthesia module with Epic.
Hi, Mike. This is Adam at VCU. We're switching over to Epic at the end of next year, and all of our data will be able to flow automatically from our pumps and really most equipment into Epic. You just need a middleware provider. It's a company called Capsule, which converts equipment data points into something that can be input into Epic. It's really low cost, and it can, I think, record every up to 3 seconds. So it's going to be very little manual entry into the chart.
All right, that's interesting. That must be it. Wow, cool. Someone finally designed it.
Yeah. That's PCU. Adam, I'm sorry. When did you say that you were expecting that to happen?
End of next year.
All right.
I
Interesting.
would be really,
Please
I'm
go ahead.
sorry, Eve. I would be interesting at how Diane, they use all that data. Like, to me, that's so interesting when you have a way to take your data and to use it to help make things better for the patients. And I mean, I guess it would have their data in it, so I don't know how they'd feel about sharing it. But even just to see a report of how Tableau, because things look so different in Tableau than Excel, like that would be super interesting to see.
Sure, I'd be happy to share it. Dr. Whitman, Glenn Whitman, is our intensivist and in charge of quality. And I know that we've had some goal-directed perfusion projects underway that kind of dovetail into with some ARS work. So we're happy to share what we're doing. We're not there yet. I don't want to make it seem like we have this phenomenal dashboard, but we are looking, at things not just perfusion, but we pull out chest tube drainage, we pull out blood utilization, we pull out fluids arrival, a temperature arrival to the ICU, and things like that. So we're happy to share.
That's phenomenal. That would. Sherry, that would be awesome. Like I feel like just to see how people are using their data, and to get anything out of Epic just blows my mind. The fact that anybody is facile and you're asking for a report and you're able to use it and export it in a way, like that is so exciting, Diane. I would love to see it.
Yeah, I'm really lucky in that I have a team that are Epic Clarity certified, and we've been doing this since 2016. Where we can pull, it's really easy to pull data out of Epic. I'm saying easy, I mean, you need a SQL programmer. The data can be a little sticky, but we pull out about 70 labs every month on all of our cardiac surgery patients. And then it just comes, it sets up a really nice tool for quality and research. And our Tableau dashboard, what we've been able to do is take our STS data and because we have a weekly M&M, and we're able to pull metrics around our index operations and things like that. So it's a work in progress, but we have had some success over the last couple of months where we're actually using it at our weekly and monthly quality meetings.
Fantastic. Would love to see it.
I think that was a pretty good demonstration of the drawing the lines, right, between practices, between perfusion and data managing. Well done, Sherry.
I'm muted. This is you. Thank you for doing this, leading this charge, coming up with this idea, because if it wasn't for you, who knew how long it would take for this to happen. So thank you. Kudos to you. Thank you. And thank you to everyone who joined this evening. Eve, did you want to leave any closing remarks before I push everyone to the main room?
Yeah, it's time to go. Thanks so much for being here and participating. It means a lot, and it I think bodes well. We will just continue to reach out to people and try to grow the group, and start to delve into some of those topics that you all liked or weighted above the others, and we'll send that survey out and see how it measures up to other people. But just thanks for being here, participating. We hope to continue to grow. Sherry, should we send out some meeting minutes just to give folks some idea about what we talked about. And please, again, I just want to implore you, if you know somebody at one of those practices that you think might be interested but may not have heard about us, just let them know that we're here. We're going to do the best we can to create a great group that you all are proud of and produces the kind of results that you want to see.
Sounds good. I definitely will send out minutes. This call actually, or the meeting has been recorded. I did start it late, but the essence of it is still there. And I will start the group, but expect an email. And thank you all for just joining and participating in this. There's nothing for you to do. So I'm going to close this room out and you should join the big room. Hopefully this works. This is our first time. Thank you for everything. And I'll see you on the other side.
Thanks, Sherry.
Okay, it's going to close in 15 seconds. Well, there we go. People are popping off. There we go.
All right, Sherry, are you there? Do you know if our perfusion meeting is done yet?
Yeah, Eddie, we're done.
Sorry about the disturbance there. Well, let's begin our session here. I see 30-some folks on the line, so we are still probably waiting for a few more, but in the interest of time, we will get started. And I would like to take the opportunity to welcome everyone to our Vcsqi virtual fall quarterly meeting. Thanks all for spending your evening with us here. I'm Eddie Fonner. Just a couple of quick housekeeping remarks before we begin our session. I'm sure over the last 6 months, this is not your first time using Zoom, so probably don't have to go over all the details here, but just please be mindful of your audio and make sure that there's no background noise. We don't want to mute you, but we might have to just in case. You can call or text Sherry if you need assistance. Here's her number. And make use of the chat feature, make use of we're going to have some interactive polling features. A lot of that is available via the participants and the chat icon down at the bottom of your screen. So please don't hesitate. This is a collaborative meeting. We don't do webinars. This is a web meeting. So we want to encourage everybody to speak up, to engage, to interact. We want to make this a fun session for you all. So don't hesitate, don't be shy. This is our cardiac surgery community, so please don't be shy, don't be afraid, and let's make our voices heard. Again, this is the chat feature here. We can, feel free to chat, feel free to unmute yourself. We should have plenty of time for question and answer as well. One other admin piece is this is a CME eligible event. So feel free to take a screenshot. We'll send out all this info to everybody who's online afterwards as well. but you can register and fill out an evaluation online for your CME credits via the VCU system. If you need any help with that, let us know. But I think it's been a little more seamless the last couple of times. So those are the CMEs. I'll just pause another second in case anybody is taking a screenshot. And with that, we have a full agenda this evening. We'll hear from our committees and all the updates for the Vcsqi members have been working on over the last several months. We'll dive into some data. We have a couple esteemed guest speakers to speak about COVID and cardiogenic shock. We'll hear about one of our member institutions and how they use data to drive quality. And we'll close it up with a COVID-19 reopening discussion. But first, we will start with our Vcsqi chairman, Dr. Robert Shor. Dr. Shor, are you with us here? I just got a text from him. No, I'm not sure if he's been able to join us yet. So I think, Dr. Spear, would you like to fill in for Dr. Shor real briefly while we wait for him?
I'm glad to. Good evening, everyone, and welcome to the meeting. I think it's going to be very enlightening and fulfilling for everyone. Our board met this afternoon and with almost total participation, and want to welcome Dr. Mohammed as our new chair of our very active and impressive research and writing group, and he'll be giving his update in just a few minutes. He's taken Dr. Gaurav Alwadi's place. As you know, Dr. Alwadi has relocated to the University of Michigan and is chair there, which is a great honor for him. But we just are so pleased with Dr. Cotter and his participation over the years, and we're very fortunate to have him. From a financial perspective, we're quite solvent and are looking forward to some new participants from the cardiology programs around the state, and watching that collaboration continue to grow. What else, Eddie? Any other hints? I think that one of the things, the virtual program, we're obviously committed to, and we know that so many of the annual meetings have been canceled, and the virtual meetings have gotten a life form. So I think we would anticipate both the fourth quarter meeting and the first quarter meeting in 2021 will certainly be virtual, and then time will dictate from there. But I think that this format has also, as an unintended consequence, has allowed those that were unable to make the drive to participate much easier, and so we've seen an uptick in our participation, and would continue to. So whether we revert back to the in-person meetings, which are always much more fun to be together at the same time, practically this is the format for at least the next several meetings. Eddie, are there other areas that I've forgotten? Because I left it with Robert to take notes. So.
Do you want to just briefly touch on Vcsqi's commitment to diversity? And
yes, thank you. I think that we're all aware of the extraordinary commitment in our country to begin to both have discussion, address, and to really confront discrimination and inequality. And I think that our board was unanimous in support of proceeding and addressing this as an organization, and what we can learn from each other, and then perhaps prioritize and look at from both the research as well as a process within our organization. Dr. Wayne Batchelor is one of our board chairs, has taken a leadership position in Inova regarding racial equality, and has just been a stellar model in addressing the differences in health delivery, the disparities between the races, and the outcomes tragically on differing care between and among race. And so we're going to ask him to sort of champion and discuss this at our next meeting. And it's quite a insightful discussion that he'll show you that is totally evidence-based and just tragic on the differences among race and the lack of as well as gender. And so we'll look forward to having that at our fourth quarter meeting.
Very good. Thank you, Dr. Spear. Before we go to our other committees, just a review of our Vcsqi strategic plan. Our mission to transform cardiovascular care, improve patient experience and value, our vision of optimizing heart care outcomes through national collaboration, innovation, and research, and our core values, which conveniently spell out Vcsqi to help you with the acronym there. Some committee updates. Dr. Cotter had to run to a heart transplant. He is taking over from Dr. Alawadi as our research and writing chair. Dr. Cotter has a vision for really taking our research and writing committee to the next level, in implementing new research processes that will help bring the findings from projects to our member institutions and see quality improvement, not just on paper, but at the local level for all of our member institutions and our patients. There are a number of ideas as well to include cardiology centers and our new data sets and really make this, again, a reflection of our heart team approach. Can I pass it to Tracey for an update from the Quality Committee?
Thanks, Eddie. Hi, can you hear me?
Hi, Tracey, we can hear you. And hey, Dr. Shor.
Okay, first off, we have our STS AQO meeting next week. Like everything this year, it's virtual, but therefore it's more affordable. And I think most of our data managers will be attending. If they can attend, or even if they can, we are also going to have a Vcsqi Maryland Data Manager Workshop on Thursday, November 5th. We'll be going all over all the new changes in version 4.2. Answering any questions, going over scenarios. We may have an expert speaker to go over the aortic section, because that always seems to give everybody lots of trouble because it's so detailed. Let's see, what else have we done? We've had 2 ARMIS hybrid training webinars. Sheila from ARMIS has been very helpful in helping us to learn their new platform and what we have to do to get our reports. And I think that's about it.
Wonderful. Thank you, Tracey. Next, I'd like to introduce Eve Dallas from University of Virginia. Eve has really taken on the lead as our perfusion task force champion. Eve, can you give us an update? We just had a perfusion task force meeting this evening, actually. Maybe there's some technical difficulties, or I know Eve was on call too. Sherry, would you like to give us an update from that session?
Sure. So the committee is pretty much full steam ahead, and we're ready just to start diving into data just to figure out how we can just make a huge impact as it relates to cases. and blood use. So in the meeting that we just had, we had our first breakout session, a virtual session that went pretty well. Our first goal is to get a representation from each facility to be a voice, if you will, or a contact within the group. Eve is very adamant, and as VCS as a whole, we're greater in numbers. So if we can have representation from each hospital to participate in this group, and most of our groups, we feel that we could be most of an asset and add more value to the patients that we serve. Expect an email soon. We're going to send out another email blast just to kind of query what are the interests, what are some areas of focus that we can be of impact for as it relates to perfusion care. And we want to dive in deeper as it relates to what systems, EMR systems, are our hospital members utilizing, and what are their integration as it relates to perfusion software into it, and how does it work, and how can we enhance it. So we're off to a great start. Eve is very energetic. The team is very energetic, and we are just looking forward to seeing what we can build together.
Thank you, Sherry. And last but not least, I'll put him on the spot here, the champion of our ERAS work group, newly minted Lieutenant Colonel Kevin Lobdell. Dr. Lobdell, can you provide us just with a quick update?
Thanks, Eddie. Can you hear me okay?
Yeah.
I would say we're in the earliest phases of forming the work group and trying to explore, engage, set an appropriate agenda for the group. Thrilled to be a part of it, representing, both ERAS efforts that we're doing internationally, as well as some of the work that we've done more locally. If anybody has any great ideas on how to accelerate us or help set the priorities, we're all ears. Otherwise, I just look forward to the ongoing efforts that you and Sherry have organized, and sure that we'll develop this agenda and develop the work product that's associated with it.
Wonderful. Thank you very much. And again, any and all, everybody in VCSQI is welcomed and encouraged to join these task forces. We need your input to make this a success. So moving right along, we have some data updates. We have Q1 data from our CathPCI repository. We have Q1 and Q2 from STS. So let's dive in. We'll take a quick look and get to see some preliminary effects of COVID, and also check in on a couple of our ongoing quality efforts. First chart shows, this is for CathPCI procedure volume by month over the last year and a quarter. Everything was real steady until we hit March. There was about a 16% drop in overall PCI volume across our member centers at that point. Interestingly, those STEMI cases seemed pretty steady. We'll, I'm sure, see something a little bit different when we get the Q2 data though. Moving along in our CathPCI metrics, vascular access site has been our core area of focus, looking at femoral versus radial access. The VCSQI state average continues to increase in terms of proportion of radial cases. However, it's still about 60-40 overall, and variation between our member programs ranges from 90% to 100% radial at some centers to 80% femoral at other centers. So still a ton of variation you'll see across every volume grouping. It's kind of like a jagged line here. So this to me would represent a lot of opportunities for standardization of practice. We'll look at a couple outcomes metrics next. This is observed AKI broken down by those two arterial access sites. You'll notice across centers, radial AKI is about half that of femoral AKI. But within centers, again, a lot of variation. Some centers have notably lower AKI rates for femoral patients than their radial patients. Overall, this is reflected in a composite chart here. This shows all comers for AKI. We've combined, done a weighted average of femoral and radial, which gives us a statewide average of about 7.4, 7.5% AKI based on that pretty stringent NCDR definition. Notably, not all patients are getting both pre and post creatinine drawn, so that cuts the denominator just a little bit. But regardless, from what we're seeing here, it's a bit higher than the national average. Dr. Shor thought of a hypothetical situation for what if we increase the proportion of patients that are done radially. So this next slide shows a hypothetical where every hospital performed at least 80% of their cases radially. So if they're already doing 80% radial, we left their data alone. If they're not, we took a weighted average for their AKI rate, femoral plus their AKI rate radially, and then weighted it based on that 80% radial assumption. You'll notice the statewide average goes down to about 7.1% and would prevent 17 or so cases of AKI. And I'll flip back and forth. Again, interestingly, some center rates go up and some go down here just based on their local level AKI rates by access site. Questions, comments on AKI and our CathPCI measures?
One of the questions that came up is what percentage of programs are using some sort of pre-treatment protocol? Are they limiting it to outpatients who presumably are more hemodynamically stable? Are they doing something different with STEMI patients? And so as we try to optimize care, there are some interesting different perspectives and opportunities with that. We know that those patients who develop significant AKI, and one can argue whether or not the 0.3 bump is meaningful, but those that do develop significant AKI, the cost is dramatically increased. So I don't know if people want to chime in as to what they do in their systems.
We have heard from a number of our centers that they are in the process of implementing or have recently implemented AKI protocols. I'm not sure if we have any data yet, though, on results they've seen.
We might want to put together, like we had for the shock, a work group just on AKI prevention and protocols.
Mm-hmm. Great idea. Next up, I wanted to provide a quick update on our angiogram review process. At this point, we have 6 centers who have completed reviews for 2018-2019 data. So we've more than doubled our sample size from our initial round of reviews a few years ago. We have seen notably a decrease in the number of lesions less than 50% stenosis. Statistically significant decrease from about 18 to about 4% of lesions less than 50% that were treated. So preliminary results from our angiogram review process, but seems like there has been some improvement in quality over the last few years. And next steps on our angiogram review process will be forthcoming. Next up, we will jump over to the open heart side of things and look at our STS data again through Q2. Volumes are pretty steady here for the most part until we hit Q2. They start to decline a bit in Q1. Again, that includes March when some of the lockdowns began. And then in Q2, it really drops over 30% for our overall open heart volumes. That's across all procedure types. I looked at this across emergent cases, elective, urgent, and emergent cases all dropped. It just seemed like everything consistently decreased about 30 to 40%. A few specific metrics. We looked at AKI on the CathPCI side. This is a risk-adjusted renal failure metric for STS. So we're looking at observed to expect 1 point. The Vcsqi line in green is just a hair above where the national rate is. But as we saw with the cardiology patients, there's a lot of variation here as well in terms of renal failure and isolated CABG. A couple quick trend analyses. We looked at both intra and post-op transfusions by quarter. And interestingly here, if this will animate, yeah. We saw the highest intraoperative rate of cryo blood products in Vcsqi since the STS started collecting this field 16 years ago. So 4.6% intraop cryo rate. The 17.8% intraop transfusion rate was also among the highest that Vcsqi has seen in a number of years. Any thoughts on why this cryo proportion is so high here? Anybody from our perfusion work group have anything to chime in on?
Eddie, this is Mike Brown at Mary Washington. Can you hear me?
Yes, sir.
It's possible if it's within that quarter of when many programs were forced to, forgo elective procedures, that many of those cases may have been urgent, emergent, and those patients may have been on, 2B3A inhibitors, anticoagulated, and may have forced their hand to operate earlier than normal, and probably that probably skewed the data. That's what I would think. I know for us, we did very small number of cases in April and May, and many of those cases were urgent, and a number of those patients were on Plavix or some other platelet inhibitor. And so we did see not a generous increase, but we did see an increase more so than normal.
Eddie, this is Alan Spear. I think that Mike's comments are well taken, because certainly with no elective cases, the only ones that we were operating on urgently or emergently were those that came in through the ED with unstable symptoms. So I would anticipate they may have indeed had the antiplatelets on board. I'm surprised that our overall volume wasn't lower than what we saw. I would have thought it would have been much lower than that. But at the same time, the other thing to keep in mind is I think it would be helpful to survey the number of new surgeons that have been come into our centers over the last 24, 36 months, because we think that our protocols are in place, but we know certainly in our system that we haven't done as good a job by continued and ongoing education that is addressing the protocols that are in place for transfusion in this case, or AFib. So there may be some institutional variation because we may not be doing as well as we could for continued updates for the benefits to have a transfusion protocol.
Very good. Thank you both. One additional view for post-op transfusions. We're probably seeing the same thing, or a reflection of the same trend, but we saw our highest post-op transfusion rate in about 7 years. Again, with the higher risk patient population, a really high number of cases receiving post-op red blood cells too. So we can definitely put a survey on that. That ties into our last item here, which is a revisitation of AFib. So for new onset AFib, the Vcsqi average is still below our last STS benchmark. At the same time, there were a couple of centers who had pretty big spikes in Q1, Q2. There are a number of best practices as well who are at about 10 or 15% AFib. So it runs the gamut in terms of levels of performance for this measure. At the board suggestion, we did send out a brief survey for AFib practices. And based on 9 responses, 8 of the 9 have some protocol in place for AFib. Some are using the Vcsqi protocol or a modified version of the Vcsqi protocol. A majority have their own protocols in place, so it'd be interesting to see how those differ from the Vcsqi amiodarone protocol. In terms of progress with quality improvement, 4 centers have seen improvements since they've started the protocols. 2 have not seen any improvements. And notably, 1 site identified some barriers to implementation based on seeing a number of patients who are bradycardic or with fascioplegia.
Eddie, is the N large enough to be able to compare the different protocols and see if one is superior to the others?
We didn't get all of our programs to respond. We'll have to kind of go back and then see if we can get more responses, as well as get those specific protocols.
Eddie, did you say that those programs that had issues with heart block and bradycardia, that they stopped doing the protocol altogether?
1 did, I believe, yes.
It would be good to be able to reach out to them and share with them what other programs have done in those similar instances, because I know that we track that and report that out each month, how many patients that we've had to hold their amiodarone and then restart. And I mean, that's not an uncommon practice. And I would imagine that Dr. Spear and his team and other hospitals have this program or this protocol in place have had the same issues. It's not uncommon. And for us, there are times where maybe in a given time, 40-50% of our patients, their amiodarone's held maybe for a day or 2 before we restart it. And, we have those measures in our order set that help to deal with that, so that by the time they do go to discharge, their amiodarone started back up. Because in many cases, we found that when we didn't start the amiodarone back up, after 2 days, those patients went back into sinus rhythm in the 70s, and then later on before discharge had atrial fibrillation. So just wanted to share that.
Thanks, Mike. Other questions, comments, suggestions about our data and quality improvement works we're continuing on with? All right, well, we will circulate an updated set of reports to everyone. This is just kind of a quick taste, but we will send these out to everybody, and your questions, comments, thoughts are more than welcome. Dr. Spear, can I call on you to introduce our next speaker?
Thank you. We're pleased to have Dr. Erik Osborn that is presenting our next segment on the our experience with ECMO and how this has been addressed. Erik was a career military and with a worldwide experience in the treatment of both hemodynamic and pulmonary insufficiency with ECMO, particularly with rapid transit, and we were pleased to attract him and recruit him to Inova about 3 years ago, if memory, I don't know the exact date, but it seems like it hasn't been that long. It came at a great time with the rapid increase in our requirements for venous ECMO around the H1N1 flu population, and he really helped to champion this population and taking control of predominantly the respiratory failure patients. And this and helped with a build up staff of around 5 very talented pulmonary critical care doctors. And it all the planets aligned with the pandemic, and what we saw was the rapid increase in both the in-system referrals and the out-of-system referrals for those with the pulmonary failure from the COVID-19 pandemic. And I don't want to steal his thunder and give you his our results, but it's been a great pleasure to participate together. And we were talking every day, 7 days a week for months, and then currently are looking at where we want our program to proceed with this adjunct therapy, which has been really revolutionary and life altering and salvaging for so many of these patients. And so I was, when we were looking at lessons learned from the pandemic, I was particularly interested in having Erik talk to us and give us the benefit of his unique experience and his vision for the future. So Erik, welcome. Thank you for coming this evening and talking to us, and really pleased to have you join us.
Thank you, Dr. Spear, and want to thank Dr. Spear for his outstanding leadership of the ECMO program through the pandemic, which has stressed everybody. I think Amy Ging is also on the call, and her perfusion team stepped up as well. And then Linda Halpern is on the call with help with some of the data. Let me get this thing rolling. So we're going to talk about our survival in COVID patients. Just as a snapshot, this is Virginia-wide for everybody with COVID. Survival is 97, and the United States is 97 also. Worldwide, this again is all patients that have COVID. You go to the ELSO registry, then it goes way down to 53%. Now that's including VV and VA, that's everyone that has COVID. And then just to put it in perspective, if you think of these are ballpark figures, there's been a range, but mechanical ventilation is about 55 to 70. In our Inova's institution, we're about 60 to 63 on our mechanical ventilation survival rate, just to give you a big picture view. So selection is the challenge. We all want to have it be black and white. And really, this is probably the most challenging aspect of the pandemic, because we had to alter our normal standard of practice. So people that we would normally put on without hesitation, we had to stop and reflect and say, wait a minute, this is really a combat medicine mentality. You have limited resources. You want to use your limited resources on the people who are more likely to survive so you can get them back in the fight. So it really isn't black and white. It was, we lived in the colorful gray. So our criteria, we had meetings with the cardiac surgeons and the intensivists and our ECMO specialists. And this is specific for COVID patients, less than 60, previously healthy, without serious comorbidities, less than 10 days on the ventilator. Some people use 7. 7 is older data. And then we use 7 for the older people. For the young guys that were otherwise healthy, we pushed it out to 10. Failing lung protective ventilation, and as many of you know, that's low volume, low pressure. We're naturally a negative pressure breathing system. Or the other criteria is acidosis compromising perfusion. So low pH, carbon dioxide's high, you're on multiple pressors. And they also have to fail the optimal evidence-based therapy. So that's neuromuscular blockade, prone positioning trial. And then we used a PDEF ratio of less than 100. Just for full disclosure, the ELSO criteria is less than 80. But if you're down at 80, one of the things that COVID has taught us is if you go on early, you do better. And we've known that for a long time, and we just further demonstrated that. So VA and ECPR, this is where it gets challenging. We decided not to offer ECPR, and that was based on the survival rates were too low and our resources were limited. In terms of thinking about VA, well, case-by-case consideration and acute reversible shock. You know, what if someone's on VV and they have a little right heart failure? What about PEs? And the criteria is pretty simple, as you guys know. It's end organ hypoperfusion despite maximal medical therapy. So these are the guidelines, but then they get challenged pretty quickly when you're in the room and you've got the potential loss of someone who's young. So this is Albert, 35, big guy, BMI is 37, COVID positive, bad diabetes. He goes on VV ECMO after failing lung protection, paralysis and proning. He's on bivalve, CRRT. His lungs are improving. He's getting better. His brain works. We're feeling good. Day 15 comes. He gets really tachycardic, hypoxic, hypotensive. Of course, it was a Friday afternoon. I'm actually walking to the car and I get a call. Mehul somehow found out that he was in trouble. He said, "Hey, are you still there? Go back to the bedside." We put him. He's got severe RV dilation, McConnell sign. MAP was in the 40s, and his oxygen saturation was 56%. So, 36-year-old about to arrest from a massive PE. What do you want? TPA and VA ECMO. Throw him on ECPR. Let him go. I think this is one of the ones where we have a. Yeah, what's you guys going to do? Now, we've got about 10 seconds to decide because, remember, he's about to code. So those are the polls. I guess people, do I get to vote? I'm not going to. So you think about what you would do. And again, remember, we'd said, well, we're not going to do ECPR. So this is a photo of his dilated RV. Here he is. This is actually his echo at the time. You see he's got his blown out right ventricle, McConnell sign, a little bit of septal bowing. I don't know, Eddie, did you get the responses on what people are going to do? Guess not. That's okay.
Actually, you should see it.
Oh, okay. I love, yeah, this is I'm speaking to a, that's awesome. All right.
And I'm sorry, I built in the second question also as well, but we got responses for that as well.
Okay. Well, you guys are ahead of me. And yeah, well, this is why I love talking to a surgical audience. It would be a lot different if you were talking to different audiences. So here's the thing. If you'd asked me 6 months ago, you're going to be giving treatment dose TPA to a guy who's been on ECMO for a couple of weeks, and he's on therapeutic bivalve, and he's having a PE, and he's about to code, I would have questioned that. I would have said, no, that's not going to happen. It just shows you the intensity of our, how the thrombosis in these patients. So he gets better, and then he has persistent RV failure. So we gave him TPA, put him on via ECMO. Persistent RV failure, we ended up doing a TPA infusion. So this is another dose of TPA, 25 milligram bolus and a mg per kg for 24 hours. We followed his TEG and looked at the LY30 to look at this degree of lysis. After 18 hours, he developed a GI bleed. And we're treating the micro and macro COVID thromboangiopathy. And a lot of talk about the micro thromboangiopathy. It's actually also macro because we've seen these giant clots in these patients. There's just his RV, and the FACC is way down, as you can see. So we put him on with cardiac surgery. The OR team comes to the ICU bed, uses a TEE at bedside, and for VA to put the drainage cannula in the RA. And then for VV, we did FEM-FEM configuration. And here you see he's able to come off ECMO. This was after TPA, after a week of VA ECMO, and his right heart recovers. So he had 27 days of ECMO support total, 21 days of VV, 6 days of VA. So what are the criteria for VA ECMO and COVID? So RV failure not responsive to diuresis, milrinone, epi, and sometimes usually inhaled EPO or nitric. You contract with the family for a 7-day run. You say, look, this is rescue therapy. We're not going to keep them on indefinitely. The great thing about the heart, it gets better or it doesn't. And these guys at this time were not transplant or VAD candidates. Most of them also have had a trial of TPA. And then again, we had decided not to offer emergent. So this was a little different. It's ECPR and a guy who'd already been on ECMO. What about this? We have a cardiac arrest in a 42-year-old who just delivered her first child via C-section. I guess you guys already made up your mind. And that's good that you did that. So she was COVID positive, but was incidental. No symptoms of COVID. They just found it because she's in the OR delivering a baby. She delivered a healthy child. She's a lawyer from Nigeria. She's large, diabetes, history of fetal loss, but a fully functional lawyer, has her own law firm over there. So we suspect a massive PE. She's getting coded by the OB team, and they call for emergent ECMO. What do you want to do here? 42, new baby, active CPR in the OR for 20 minutes. Let's get some more information. pH is 7. You all heard pH less than 7, go to heaven. Oxygen saturation in the 90s, so our lungs are okay. Happens that we've got a team free to cannulate immediately. So emergent VA, let her expire. So you guys all chose emergent VA. That's 86%. Okay. So there are some people that said, so that wasn't 100%. So this one was harder. We didn't. This was a harder case because we didn't expect. We ended up getting her on pretty quickly. 52 minutes of CPR. Heart and lungs recover. Her brain does not. She ends up having refractory DIC and multi-organ failure. And then the ischemic valve led to withdrawal of care. But we at least gave her a chance, and it was also a shorter run. Let's talk about Rodrigo Valderrama, 30-year-old healthy aside from hypothyroidism. Ramesh Singh puts in the cannula, and he said, what's going on? Did you guys give the heparin? Yeah, they did, 5,000, but his cannula completely clotted off just in the time that he put them in. So he did a great job opening them up. This guy doesn't get better after a week of EV ECMO. What are you going to do? We thought he would get better because he was one of our healthiest guys. He was a Colombian Army graduate, Special Forces in the Colombian Army, now here healthy. So we ended up giving him convalescent plasma. Interesting discussion here as well, what dose? You've got the ECMO circuit that's going to absorb some, and he was on high flow CRRT. Do you give him a higher dose? We talked to pathology and ended up giving him a standard dose, but he got 2 doses. And then we put him on prone position while he was on ECMO. And that's one of the things that we learned and we did more frequently in our COVID population. So he's getting prone, and that did appear to help his lungs. We also mobilized our patients with specialty beds. So when they're sedated initially on ECMO, you could lift them up and verticalize them, we call it. Technically not a word, but sitting them up, and it did help move things around. So this guy I'm talking about, the 30-year-old, his lungs recover, but he's got a dense encephalopathy. So he ends up having COVID brain. This is specific to all of the 40 patients that we did. Neurologic dysfunction, about 35%. It's a lot of them. Encephalopathy was common. Then again, is it multifactorial? They all also had a lot of sedation, and they were pretty sick. But there was something else. They didn't act like normal patients on VVECMO. So a lot of them presented with hallucinations that improved with time, seizures that we found when they were non-convulsive often, and also they improved or resolved with treatment. Autonomic dysfunction, very high rate of that, and it's really hard because all of a sudden their MAP goes to 40, and you run in there, you're going to give a little epi or something, and then their MAP is 200, their systolic goes to 300. So you had to sort of just ride it out, and we know based on how the virus enters the brain that it is a component of the COVID brain, the autonomic dysfunction. And if anybody has an answer for that, let me know, because we haven't been able to figure it out. The other thing we did in our patients, which was different, was we had a subcutaneous EEG. Gives a better signal than a scalp EEG. And we implanted that in 14 COVID ECMO patients. So here's a picture, and this is another one. If you said 6 months ago, you're going to be taking a little wire, which you see on the left there, and someone's going to be on ECMO, they're going to be fully anticoagulated. You're going to stick that into the subgaleal space, which thankfully is not very vascular, along with your neurocritical care colleagues, and you're going to do that on ECMO patients. I would have questioned it. We did it. The bleeding was not that bad. There was some bleeding, but it's bivalve, so it responds a little better to pressure. And bivalve requires movement, as you know, and with pressure, you can achieve thrombosis a little faster than with heparin. This is the subcutaneous EEG. We found seizures in these guys. This gentleman that I'm just talking about now, the 30-year-old, not waking up. He's not convulsing, but he was having seizures on scalp, the subcutaneous EEG. This is the main screen. There's a lot of data. Don't have time to go through it. The point here was you can monitor sedation, looking at the burst suppression ratio, because you want them comfortable, but you don't want them, you want to be able to monitor their neurostatus. And you can also look at the relationship between hemodynamics and brain activity. There's a lot of variables that this screen is pulling up. So this is an area of research that's investigational. This is all approved by the FDA, and we're going to be sharing our experience in more detail about that shortly. This is Rodrigo Valderrama, 2 months in the hospital. We're surviving COVID lung, seizures. He had a trapped lung, ended up having to go for a right decort. Still in this picture has most of his right lung whited out, but he just texted me today. I said, hey, can I use your picture for these talks? He said, yeah. He went 3 miles on the treadmill, so he's doing great. So here's going back to this selection challenge. 60 years old, outside hospital, failed lung protection, neuromuscular blockade, prone positioning, PDEF ratio is 75, pH is 7.1. He's on moderate dose norepi for shock. He's day 10 on the ventilator, acute AKI requiring CRRT for 3 days. This patient was previously healthy. He's the pastor for a large local church. Do you accept him for VVECMO? You have 1 ECMO bed left. Yes or no? So this is a hard one. And it goes to the challenge of pandemic medicine, and it really reminds us a lot. There's some military on the call, and it's really what you have to do in a combat zone with limited resources, and it's almost a dynamic standard of care because it has to change. So Sherry, you have the results of that? I'd be curious. Yeah, okay. Excellent. Well, of course, we wanted to accept him. At this point, he's multi-organ failure. You know, you could say, well, the shock was from his lungs, but the kidneys were down. 10 days on the vent at the high end of our age range. If we'd had multiple ECMO beds at the time, we probably would have, but we had one bed left. So we said no, very difficult to deal with. But the very next day, our last bed gets filled by a 34-year-old who's otherwise healthy. So that's the reason that it ended up making us, there's no way to feel good about that decision, but it tells you the challenges of what you have to deal with. COVID thrombosis, just to go through some of the side effects, over 50% of the patients manifested as circuit exchanges more frequent, more clots in circuit tubing, despite anticoagulation. We started off PEs and acute RV failure in a lot of patients. Well, not a lot, probably 7. Lower requirements for blood products. We didn't have bleeding problems. A higher rate of heparin resistance, require more anticoagulation. In the beginning, we were using both heparin and bivalve, and then we pretty much switched, do a very large heparin bolus and then go right to bivalve. Start the bivalve even before, you don't wait for the PTT to come down or the 10A to come down on the heparin, but we started up right away and keep it going. Because we just didn't have much in the way of bleeding. I know our colleagues at Penn had some head bleeds, and there's been other head bleeds around, but we have not, aside from one pregnant patient who got a head bleed after ECMO who was on Lovenox, it wasn't on ECMO. So pulmonary hemorrhage happened in a handful of patients. So, I'm saying that about 10% of our patients, we did inhaled tranexamic acid, and we lowered our bivalve, the PTT target for bivalve, cryotherapy for refractive airway thrombosis, and then we used surgical suction, the Stryker Neptune 3 machine. Again, this is not approved for airways. It'll rip your airways apart if you get it in the wrong area. So we did it with thoracic surgery, and we're extra cautious. It worked very well and very fast, but also a lot of consternation because that thing will rip you apart, as you guys know. The lungs recovered after the bleeding was taken care of. And we did regular bronchoscopy because we had a high rate of secondary infections. Pneumothorax, again, talking about the lungs again, about 20% often later in the course. And this is the guys who've been breathing hard and fast and been on the vent for a long time. How did they die? Multi-organ failure, usually in the setting of an underlying infection. RV failure, your micro and macro thrombosis. The survival rate of people who went from VV to VVPA or VAV was not as good as just the straight VVs. We got a few people through, but a lot of them didn't make it. No lung recovery and not a transplant candidate. We tried to get a couple guys listed, but they just complete biventricular failure. The guys in Germany were asking me about this today earlier, and we thought we might see more. We saw 2 of these where the heart just stopped, the whole thing, both sides that just stopped, and it was bizarre because the troponins weren't elevated. And they call that COVID heart. I know what they described in Italy and what some of our colleagues saw in Seattle. Didn't see as much of it as we thought. We did have 4 or 5 that died of cardiac causes before they could get on ECMO, before they could get to us. Guys are calling us from outside hospitals. Interestingly enough, our second wave, and this is a smaller group of patients, second wave of COVID ECMO patients have had worse outcomes. Why is that? Virus mutating. Usually as viruses mutate, you think of the flu, it gets weaker. Is this one mutating into a more virulent strain? Or are we trying to avoid the ventilator and these guys are staying on high flow nasal cannula and non-invasive positive pressure ventilation, so BiPAP? We've had a few that were at, say, another Virginia hospital center for a month on high flow and BiPAP, and then they come to us, we intubate, put them right on ECMO, but the damage is already done. You look at their lungs, it looks like an advanced ARDS, they've got early fibrosis. So that's the sort of the fast breathing lung injury. There's a term for it, we debate it in the literature, PSILI, patient spontaneous induced lung injury. I think it's a real thing, and I think we're seeing it in some of these patients. Again, this is speculative in terms of why, because it's a small number of patients. So where are we? Overall experience as of now, 33 VV ECMO runs completed, 24 home with intact brains. And so a success is home and independent, not home and, you know, in a home or in a vegetable. So 72.7 survival rate for VV, which is quite good. 5 V ECMO runs, ECPR, 2, 1 made it, and then the VA for acute PE didn't do as well. Usually VA for acute PE in a non-COVID population, they do very well. You're looking at an 80% survival if you can get them on quickly. These guys didn't do as well because they also were sick with their lungs. So in conclusion, ECMO successfully supports patients with COVID lung failure and multi-organ dysfunction. Again, I think it's better than mechanical ventilation. Our numbers suggest that, and ECMO is a limited resource. And you can argue about, well, do you want to invest all the money to build up your ECMO team and infrastructure to put everyone on ECMO? If I go down, just put me right on ECMO. You can skip the ventilator. And my background is in pulmonary, so that should tell you something. Stricter criteria, increased anticoagulation, and frequent prone positioning, what we did. So this, VV really you can put just about anybody on in a non-COVID situation, but we had stricter criteria because of the pandemic. Higher PTT goals, frequent prone positioning. Again, we talked about the increased thrombotic complications in 25 years of practice. This group of patient clots more than any other I've seen. The second wave of COVID patients, we talked about worse outcomes. And then again, the later findings of neurologic dysfunction that have been treatable. This has gotten better. So this is important to remember. It gets better. And if you talk to all the guys that are at home now, they're doing well. Some of them have pain and shortness of breath, but they're rock climbing, they're running, they're riding their motorcycles. They are back to living pretty normal lives in spite of being incredibly sick. So that is all I have. I think I made it under 30 seconds, and I will hand it back over to you. Thanks for inviting me again.
Hey, Erik, this is Alan. Could I ask a quick question for you?
Yes, sir.
As we're going into the fall, and already it's in the 30s at night out where I live, but we know that testing is still somewhat challenging, and as we get the flu patients that come in, even if 20% of them have false negatives, what are your thoughts now with the series that we've had, and that the patients that we've kept on, with some of them out past 60 days? Do you think that the criteria should be augmented or modified? And if so, how do we build in what we've learned from those that are outside the institutions that have been on high flow for several weeks? How does that change what we're thinking, or does it?
Excellent questions. I think we can, we're sort of speculating why this last batch hasn't done well. I think for the COVID population, we keep our criteria strict. And like we've talked about in the old days, in our consent, it used to have 15, 16 years ago, we had after 2 weeks, if you're not better, you just came off ECMO. We didn't have a discussion. You didn't have to have ethics and palliative and hours of meetings. 2 weeks, they're not better, they come off ECMO and you go back to normal therapy. If we end up getting really busy again, I think we do have to say, listen, let's say at 30 days, if they're not better, do we need to reallocate their machines? Because you have one guy on for 3 months and you could put several other people through that ECMO bed. So in terms of limiting the time on VV, I think we have to look at, and then we're already planning. You've done a great job of anticipating the future and building up our infrastructure so that we can accommodate more. And we have to also remember we need to maintain everything else. This is just one small part of a much larger health system. So we need to make sure we can do all the things, take care of the cardiac surgery patients and the VAD patients and the transplants and the shocks. We don't want to get overwhelmed with long-term ECMO runs.
Well, thank you for all that you've done for us in the program, and I know it's been a haul, but I think it's been very productive and enlightening. I don't know how it's factored with some of your colleagues from around the world, and if this has been the same type of experience they've had, or do you think that it's been different? Have we seen things different here than else? What is your feedback?
I think the big centers that were well resourced and had time to prepare, we've had some excellent outcomes. Just to give you a point of reference, the ELSO annual conference starts tomorrow, and guess which ECMO team is presenting for the United States. They have a section of COVID ECMO, and there's the United States, France, China, Japan, and Chile. And they were, so the Inova ECMO team is going to be presenting kind of a similar situation that we did. We had good outcomes, and we had great teamwork, and with cardiac surgery and with the ICU docs. And then we had support from the senior administration, which you did a good job of marshaling. I think that we've learned that COVID, ECMO works in COVID, and this is only going to expand the use of ECMO for other areas. And lots of other places around the world are trying to, and in this country, are building up their own ECMO capacities. So it's going to expand ECMO, and then we will need more beds, more people, and more equipment.
Erik, this is Bob Shor. Great presentation. Are there any other anticipated changes in the protocol, whether it be age or any of the other criteria that you see coming down the pike?
You know, I think we might say, based on the last group of patients that were on this non-invasive positive pressure ventilation, you know, you all know right now you're breathing, we're a negative pressure breathing system. You're like 5 centimeters of water in your pleural space. So you go on high flow and you turn it all the way up, you can generate 5 to 8 centimeters of water, even despite the upper airway covering, you know, catching a lot of that. So the lungs are getting beat up. And you can say if someone's been in a hospital breathing in the 30s and 40s on high flow for a long period of time, maybe they're not a good ECMO candidate. And we've been real busy late and didn't have very many beds. So we've had to decline. The last week, we declined 3 or 4 patients that were sort of in that category, because it doesn't make sense in terms of resource allocation to say, let's put this guy on and keep him on for 3 months, and his chance of survival is very small. So I think that would be one of the things to look at, and we need to go back and look at what's going to happen with, I think overall that well, I mean, I don't know I think that if you took someone as soon as they got sick and they went on really high settings of high flow nasal cannula, if you could put them right on VV ECMO at a high volume center, I bet you they do better than mechanical ventilation. We're not resourced to do that, but my opinion for what it's worth.
This is Sula Mazimba from UVA. Erik, I have a question for you. Great presentation, by the way. With respect to the phenotype of patients on ECMO who are improving and doing well, are you able to get a sense of kind of the pattern of patients that are doing well rather than doing poorly?
The patients that did the best were ones that were within 2 to 3 weeks in their COVID illness. So if you think about it, someone gets COVID, 10 to 12 days, they go in the ICU, get intubated. And then if that group, so they've only been sick for a couple of weeks, and then they go on and you do your neuromuscular blockade, your proning and your PDEF ratio is low, you try to protect their lungs and you can't, as soon as you can, so I'm talking hours, then you pull the trigger and you put them right on VV ECMO. That group has done the best. And what happened was we said, oh, well, we're going to conserve ventilators. Let's put them on high flow, have them prone themselves, and we'll bleed in a little nitric. Maybe that helps. It works for some, but the ones that don't, that group has not done well. because you're ending up putting them on the vent at a month, and then they go on ECMO after they've been sick and been in the hospital for a longer period of time. I don't know if that answers your.
Erik,
Sure.
the other point was that the first 15 or 16 patients on ECMO, I think about 13 out of 16 or 17 were Hispanic. And for a while, I thought that it was the Hispanic population that was inordinately at higher risk for more rapid progression and more severe disease. But I think that we saw that didn't end up over time, and increasing numbers wasn't necessarily limited or prone to different populations. Is that accurate?
It is. We still have a high, in this area, a very high rate of Hispanic patients on ECMO. They've actually done a little bit better. What is interesting, we were discussing this last night with Mehul Desai. It's people who've been in this country not very long. So like you have to use a Spanish interpreter. They haven't been here long enough to really learn English. So it makes me wonder, they have been in Honduras or Ecuador or Mexico. They haven't been exposed to the subtypes of coronavirus that, say, we have been exposed to. So we've developed a little bit of innate immunity to this new one because of what we were exposed to in our environment growing up in the United States. Again, this is highly speculative, but there has to be, certainly there's a genetic component, but it's interesting that the Hispanics that are getting the sickest are ones who have not been here for very long.
Erik?
Yes.
Hey, Jeff Rich from Virginia Beach. Thanks. It was a great presentation and fantastic results. Question for you. This is before the patient gets through the gates of ECMO. You know, for that patient who comes in who has infiltrate COVID-19 positive with the amount of thrombosis that you see, do you start them on high dose anticoagulation right away, even before they go on ECMO?
Yes. Yeah, most of so we did not necessarily high dose, but our guys were all on IV heparin, you know, with the PTT goal of 50 to 75. So low intensity heparin. And then if we saw any type of clotting or heparin resistance, which is much higher in this group, then we would turn it way up or just put them on bivalve. But absolutely, that was part of our and I could have mentioned that one of the things that helped us was that our critical care docs have a very strict ARDS protocol, as in they follow 6 cc's, less than 30, paralyzed, prone, got steroids, got IV heparin. Whereas if you look at the patients that we took from outside centers where they were using APRV as rescue therapy, it makes your numbers look better, but the volumes that are required to do that hurt the lungs more. So that group of patients that came into us has not done as well as the ones who were in our system and then had, you know, kind of, you know, best evidence or optimal evidence-based therapy before they went on. With the addition of IV heparin, most got convalescent plasma. We did some IL-6 inhibitors, but that led to a lot of secondary infections that actually caused a lot of problems down the road.
Thank you. Another question. Do you think there's a difference between central and peripheral cannulation?
Absolutely. We didn't do any of ours centrally. Again, it was, you know, we've been very fortunate, our ECMO team and the surgical team, the OR. I mean, Amy and Linda, correct me if I'm wrong, we haven't had anybody get COVID. I think one anesthesiologist recently got it from his son who came back from college. But in the beginning of this, we weren't sure how, we were being careful, so we didn't want to take them into the OR and expose a larger group of people. So we did peripheral cannulation and did not use central in anybody. I know that it would work in kids better, but for adults, we did peripheral.
Thank you.
Very good. Well, thank you again, Dr. Osborn. We greatly appreciate you taking the time to share your experiences with us, and we would love to have you back. You would always be welcome at Vcsqi. All right, thank you again. Our next presentation, we will hear from a physician we were introduced to at our meeting in June, Dr. Behnam Tehrani, the director of the cardiac cath lab at Inova, has taken over as the champion for our new Vcsqi shock work group. Dr. Tehrani, please take it away. I will turn over the screen to you.
Great. Thank you very much, everybody, for this evening. Let me share my screen here. Oh, great. So again, we know we've all seen this data, so it doesn't, much time shouldn't be spent on this, but we all know that the survival and shock now for more than 20 years, since we've shown that early reperfusion is the standard of care, really has stagnated. And this goes back to the initial shock trial, and now even onto the most recent contemporary studies with culprit shock, and then the 6-year data with shock, IABP shock 2. Short-term and long-term survival is very poor, less than 50%. And we've all seen how these patients behave. They come into the hospital acutely ill, they're cold, they're clamped down. Then they very quickly, within a short period of time, go down this proverbial hemometabolic cascade of end organ hypoperfusion, lactic acidosis, refractory arrhythmias. They develop bacterial translocation, and then ultimately, the final common pathway is death. And as we've talked about before, not all shock is the same. These patients can present with LV dominant shock, RV dominant, and as it's been shown recently from the cardiogenic shock working group, 55% of patients, up to 55%, can present with bi-V shock. And we actually just had a nice case that we discussed at our cardiac ICU M&M just a couple of days ago in terms of how difficult these patients are to treat. And there's obviously this very unique phenotype of pre-shock in which these patients look better than what their numbers are. And they come in clamped down, tachycardic, very cold. And these are the patients that can very quickly deteriorate if they're not recognized quickly. And this chart shows that invasive hemodynamics can really show how these patients are different, and they clearly have very poor outcomes. And just as not all shock is the same, not all devices are the same, Dr. Osborn's expertise is in ECMO, and we've seen clearly that this device can provide great cardiopulmonary support, but it comes at the expense of afterload. And so there really comes into play this plug and play formula in terms of how these devices should be applied based on hemodynamics and based on providing not only good cardiopulmonary support, but also unloading of the chambers. And so that's why this group came together. We've clearly seen all of this data. And so this organization was kind enough to put together this working group, which consists of George Washington University, Inova Heart and Vascular Institute, University of Maryland, UVA, Valley Health, and obviously under the umbrella of Vcsqi. So we initially started with a survey, internal survey amongst these group members to ask, where do you currently stand in terms of understanding your institution's protocols and how you approach the care of these patients. And as you can see here, it's a wide, there's some wide variation in terms of whether shock protocols exist, whether they are in development, or whether they are, almost to completion. And as you can see here, we had 2 meetings on August 25th and August the 9th. These different institutions were in different phases of implementation. Each of these institutions also involved in different multi-center registries, whether it's the National Shock Initiative out of Detroit, the Cardiogenic Shock Working Group, which is out of Tufts, and then the Critical Care Cardiology Trials Network out of Harvard. And again, we all agree that there's a lot of heterogeneity in management, definitions. One of the things that we'll talk about is protocols, not just for insertion of devices and recognizing the device, but weaning and escalation. And we had talked about that in a case a couple of days ago internally around understanding when to escalate, whether it's due to refractory shock or potential device malfunction. And another really important aspect of this is vascular access protocols. I think many on this call will agree that one of the main reasons these patients in shock die, not only can it be due to late recognition with refractory pump failure, but if, on the other hand, they're recognized early and they get a device, it's vascular complications and bleeding, which can really be a major problem. The most recent sub-study out of the culprit shock trial that was just published 3 months ago in JACC Intervention. In that study, and that was a randomized controlled trial, which compared early culprit versus multivessel revascularization, showed that the total bleeding rate was 21.5%. And when you look at that, when you look at the paper that was published at the end of last year from the Premier database that was published at the American Heart Association, and then subsequently the data that came out of JAMA Cardiology, 20 to 25% is a very consistent number. And that's at high volume centers that do a lot of large bore access, do complex interventions, structural heart, complex coronary disease. But 20 to 25% is a really important number. And that's been a clear driver of outcomes. In fact, in the culprit shock study, when they did a multivariate regression analysis, they showed that Impella and ECMO were the drivers of that. And so the goals and objectives of this group was not only to understand how we can approach this disease process, but not in a way which would be prescriptive or would require a randomized controlled trial, but to really understand what are the current data collection tools that are used at the various institutions. Can we come and coalesce around a common case report form? And through that, and by understanding better, not just within the 4 or 5 centers that we showed, but broadly within the tri-state area, how shock is understood and how the data is collected, can we come up with some clinical questions that could advance care of this critically ill patient population. So UVA was kind enough to provide us with their case report form. And as you can see here, they use very similar data. They use the clinical criteria from the shock trial, not based on not only hemodynamics, but metabolic criteria. And they also had exclusion criteria. So patients that were terminally ill, that had DNR status, if there was not a purely cardiogenic component, if there was septic shock, they were actively bleeding. And they used this interesting CGRAPH score, which was published from UVA, in which, based on the patient's comatose status, based on their pH status, their age, if they were greater than 3 points, they were considered high risk. And obviously anoxic brain injury, which really, when you look at them, is in the patients that present with cardiac arrest complicating shock. And cardiac arrest, unfortunately, is rather common. Up to 50% of patients will develop cardiac arrest. And when you look at data, whether it's from sub-studies of these trials that we showed, or other registry databases from the nationwide inpatient sample and elsewhere, when you mix cardiac arrest with cardiogenic shock, it's a very synergistic outcome in terms of poor long-term outcomes in these patients. So again, they collect data, age, gender, survival of discharge, devices. If it was an AMI shock, their post-PCI TIMI flow, what were the vasoactive medicines, and looking at hemodynamics over very finite granular points in time, and collecting data from the echo, but also as well from the hemodynamics. And then again, whether they needed a CRRT, mechanical ventilation. I think we would all agree 70 to 80% of these patients, unfortunately, are intubated, and we've seen, like Dr. Osborn showed, a fair number of COVID myocarditis patients. And then obviously, with regards to their disposition, was it a survival? Did they have native heart recovery? Did they have a durable VAD, required transplant? Or unfortunately, was it hospice? Winchester, again, also provided their data as well. As you can see here, very similar findings, looking at baseline demographics, what device they got in, was a device escalated, when was a device removed, were there complications associated with the device? I think this is a very important point that the group out of Winchester has been looking at. It's not only hemolysis, which can happen with these axial flow devices, with the pigment nephropathy, but vascular complications. Was there a need for a distal perfusion catheter? And at our institution, I think it's become empiric now that when somebody gets VA ECMO, they will get a distal perfusion catheter. And when we put in Impella, we'll oftentimes do a runoff angiogram, usually transradial access, taking a vert catheter down and seeing if there's flow down to the SFA and the popliteals. And if there's not, then we will oftentimes put in a distal perfusion catheter. Complications, stroke, vascular bleeding, transfusion, length of stay, and disposition. Again, similar hemodynamic data as we've talked about, the complications as we discussed. And at our institution, again, we also shared what we've been looking at, again, based on demographics. One of the questions that we had asked, and as you'll see, we'll discuss in the survey, is do we have risk stratification models or scores that we look at? A number of scores have been proposed. As you recall from the IABP Shock 2 trial, there was a score that came out, again, looking mostly at the AMI phenotype. The European group also came out with the CARD shock score, again, heavily tilted towards the AMI because they actually get 1 point if they have AMI versus 0 if it's a non-AMI patient population. And now we have this evolving SCAI classification system, which came out a year ago and is still undergoing iterations looking at pre-shock, looking at patients at risk for shock, pre-shock, classic shock, deteriorating shock, and an extremis, and it also assigns an arrest modifier. And again, as you can see here, one of the questions that was asked is, how easily can this be married to the data that's in the NCDR CathPCI registry? And as you can see here in the blue, a lot of the data is not, unfortunately, when it comes to the hemodynamics, the troponin levels, but there are others that are what their blood sugar is, if they had a cardiac arrest. And then finally, looking at what was the device they got, escalation, did they get it, if they went on VA ECMO, was there LV venting? That's not captured. And then the outcomes, again, similar to what our colleagues from the other institutions showed. So with all of this together, we decided that, clearly, these 3 institutions are very similar in terms of how they approach these patients and what they look at, with some variations. But I think it became clear that there may be some more heterogeneity outside of the smaller group that the Vcsqi has helped to adjourn and bring together. And so we decided to come up with the broader survey, which we put out. It's now digitalized. It's 47 questions, and it's pretty comprehensive. We felt we had, we disseminated this across the entire group of partners on this initiative. And it starts off, and it's multiple choice, and it starts off with simple questions as, does your institution have a shock team? If you do, who are the members on that shock team? And then we really go down into detail, asking about, where you would fall into a classification scheme of shock centers 1, 2, and 3. Also, do you have do you have a fully capable 24/7 cath lab? Other questions that we asked are included around ICU coverage, and I think as Dr. Spear and as Dr. Osborn have discussed, and this is an area of their expertise, critical care management of shock. And while recognition in the emergency room and the cath lab is crucial, really the work begins once they go into the ICU with the continuous longitudinal care and management under the aegis of the cardiovascular critical care team. And so we asked, do you have a closed ICU? If you do have a closed ICU, is it closed with a medical intensive care model? Is it closed with a cardiac and in medical critical care co-management model? Or is it one of these very rare models which exists around the country, a few places, which is cardiac intensivists, whether they're anesthesiologists who have cardiac critical care training, or or cardiologists who have also critical care training. And we go down this pathway, and we've asked a series of questions. And our hope is to disseminate this survey, get a better understanding of where other institutions in this tri-state area, outside of the handful in this group are. And then through that, if we can come up with some clinical questions through which we can gather data, and to hopefully be able to answer some clinical questions that would maybe perhaps further inform our management for this very vulnerable and frail patient population. Thank you.
Thank you, Dr. Tehrani. Questions, comments about our shock team before we move to our next segment?
Behnam, this is Alan, and thank you again for taking the leadership, not only in our institution, but in our organization. And I think certainly it's in the nascent phase of beginning to get the collaboration and the involvement. And I know it took us about 4 years to get sort of the consolidation in a core group of institutions, not all, but the larger ones that were willing to sort of look at this uniformly and then be willing to accept that whether it was a transfusion or early extubation or renal failure or AFib protocol. So don't be dismayed by the sort of the slow start out of the gates, but I think the other thing is, coming up with sort of some consistency between and among the groups as to how we uniformly can expand that, both in centers that don't have cardiac surgery backup and then those that have an aggressive freestanding cath lab, that we could come up with sort of modifications of how to handle these higher risk patients. And I guess the only other thing would be how to incorporate the whole cooling Arctic sun approach more expeditiously sooner, and what role that might play for preservation. Do you have any thoughts to that? Or
Yeah, no, thank you. That was those are some excellent points. So to address the first question is, how do we want to collaborate and provide the resources and the expertise to these, I guess, level 2 centers, as you could call them, the ones that have a cath lab, can do primary PCI, will do a balloon pump. Some may even do an Impella, where they may keep them for a few days or just do implant and ship. I think that's still an evolving question. We clearly see that there is variability even amongst those institutions. The ones that do more Impella or have fewer operators that have large bore expertise, they will quickly recognize, they will stabilize, and then correct acid base impairments and ventilatory issues and transfer. But we've also seen times where somebody may come in with a big RV infarct and they're clearly in shock and they get an Impella CP, and that can be an issue. And then the sequelae related to vascular complications and bleeding. And by the time they arrive to a level 1 center where they may need ECMO or go on to require further evaluation or destination therapies, they have been set back because of these complications associated with that. I don't know if we have an answer to that. I think there's clearly some biases that exist in terms of how to treat those patients. I think as long as we continue to emphasize early recognition, stabilization, and do it locally and with the expertise that may exist, that's critically important. But recognize that these patients should probably get to a level 1 center where the ongoing discussions around destination therapies can happen. To address your second question, I absolutely agree with you. I think therapeutic hypothermia is crucial, especially as these patients may present with a cardiac arrest, either as their initial presentation or as a consequence of their shock state, either in the cath lab or when they're initially in the ICU. And preserving neurologic function, or at least giving the best chance of preserving neurologic function, is critically important, because then otherwise it really becomes more of a palliative proposition. So I completely agree with you, sir.
Behnam, this is Bob Shor, and again, a fantastic presentation. I look forward to the output from the group and looking at best practices and bending the curve. I did want to underscore that I think outreach to the often community hospitals, as you well know, in Northern Virginia, we have a bunch, and the education that can pay dividends on the front end, so that we transfer patients earlier when we can actually intervene and do something, becomes critically important, and not sitting on patients and wait till they're really beyond what we can do. So I don't know if you have any specific programs, or if the work group has anything in particular as far as educating some of the peripheral hospitals.
Yeah, no, I couldn't agree with you more, Dr. Shor. Those are very sage points. I think one of the key things that needs to come out of these initiatives is for our respective institutions within our own respective regionalized system of care for these patients, is to develop outreaches to our sister hospitals, so that we can at least provide them with the resources in terms of contact information. And by contact, we literally mean one call, an easy one call system, and knowing what the criteria are to diagnose and get the patient stabilized and expedited and transfer. I know that within our own health system, we're doing that within the Inova health system and the hospitals that are within a very short radius of ours. And clearly, I think as we work with the other respective institutions in this work group and within their own regionalized systems of care, I think that's one of the really important things that can come out of it. Again, I think one of the things that we learned was that it wasn't creation of new devices or technologies, but it was communication, collaboration, the creation of a one-call system. I think any physician who is taking care of these critically ill patients at at a center that may be level 1 or level 2 or level 3 really wants to be able to have access, easy, meaningful access to the level 1 center where they can communicate and get these patients. But also equally as important is at these level 1 centers, if we are going to take on these patients and provide care for them, to communicate regularly with the referring team, provide feedback, provide them updates of the patient's care. And that's critically important to reinforcing this hub and spoke or regionalized system of care model.
Thank you.
Robert, do you foresee on a Commonwealth level we could somehow have more interface with VHAC and the SHOC group? I mean, we're both seeking many of the same comparable things. I don't know as much about the organization, but we're really setting up sort of a much more aggressive and collaborative regional approach to this. Is there a way to consolidate some of this energy?
Yeah, so I think VHAC, I don't know if Mike is still on the call, VHAC is really setting up the STEMI network. And how do you provide timely care to those patients? The shock patients are often shortly after that. When do you decide to transfer? My grandiose view is if we could incorporate VHAC with Vcsqi along with the shock and whatever other things that we think would be appropriate in the future that we may or may not know would be great. We are in conversations with VHAC as to how we can be more collaborative and integrated. Where that goes, I think in part, will largely be dependent upon whether or not we're successfully able to merge the registries that were mentioned earlier to be able to provide a single platform. And if we can do that, then I think the next step will be a larger collaborative.
Hey, Bob, I can speak to that. This is Pete O'Brien.
Hey, there you are. Great, Pete.
Hey, sorry I was running late in the office today, but very glad you asked that question. We actually just had an in-depth call with ARMIS. This is kind of down in the weeds, and then I'll give you the higher altitude view in a second. We just had a very productive and in-depth conversation with ARMIS and AHA and looking at the various registries. And really our vision has been to try to bring that cooperation and that data together through Vcsqi, because VHAC is a statewide coalition that's committed to quality STEMI care, and Vcsqi really has the same mission in that and many other areas. So an emphatic yes, that we want to bring our STEMI network more in line or collaborate more with Vcsqi. The call with ARMIS is more the nuts and bolts of how we bring the data together from ACC, AHA, the two different registries. In terms of shock, that was a fantastic presentation, by the way. Dr. Tehrani also gave a great presentation to our VHAC state meeting when we were able to have that in person. Let's see, it's 2019. So we have been very interested in that. We're always looking for ways to leverage a statewide system that's been in existence for a decade to other areas of care, cardiac arrest, shock, things like that. And we've begun that work. But again, short answer is yes, we're very, very enthusiastic about that. And that work is well underway. So hopefully at a meeting in the not too distant future for Vcsqi, we'll be able to bring you more of the specifics and the progress to date. But definitely yes to that idea.
Peter, I think it's fortuitous that we've got ARMIS sort of at the center of some of these discussions, because our database managers are so overwhelmed with these different registries and just collecting these reams of data that is almost overwhelming everyone, particularly them. And if we could come up, and Behnam's got this great but extensive survey, but if we could begin to have them extract the necessary information that you all need for the ST elevation, for the shock, for us on the surgery end with the ECMOs, and then we're not replicating everything. We can use a central extraction through ARMUS that could even combine that some of the cost information as well. Would be very unusual and expansive, and really bridge the cardiology and surgery sort of groups in a different way.
Absolutely. Yeah, no, absolutely. And unfortunately, this is a perfect storm with COVID and the challenges of the care of these patients in critical care and how STEMI presentations have dropped off. But health systems are squeezed right now. This isn't a great time to go and have to ask them for more data abstracting resources. So what we did in a nutshell was we basically distilled 5 different measures that are important. First, contact to balloon, a few other things that are very narrowly targeted wish lists. If we have these measures and we can obtain those from our 42 or 44 PCI centers across Virginia, then we're in a really good position. The other thing I would mention too is that Virginia will be on the forefront of an effort like this, because I've had a lot of conversations with STEMI leaders since the action registry went away. And honestly, a lot of regions are in disarray. They don't have a measurement tool that can bring their state data together like they used to. If we can pull this off and we can synthesize this data through Vcsqi and through ARMUS, it's going to be very exciting. I think we're going to be way ahead of the game in terms of STEMI care and all that's related. So we're pretty excited about this.
Let's continue those conversations, Pete, about other ways we can collaborate and interact.
Sure.
I think you have the attention of a lot of the frontline cardiologists, interventionalists, and to get them more involved in this, both in the shock and just some of the other Vcsqi initiatives would be great.
Great.
Dr. Spear, Dr. O'Brien, this is Tracey. I am the STS database analyst. We do not collect a lot of data on your ECMO, on your Impala. All we collect is if you had it or not. So to add it to the surgery side, we're going to have to do some Vcsqi specialty fields, which we've done before, especially for the blood conservation. We did a lot of specialty fields. Just keep in mind that these ladies are busy, but we would certainly love to help you do that. But it's going to be specialty fields. It's going to be other extra fields to code.
Thank you. I'm really sensitive to this because I'm up to my eyeballs in the IQVIA data migration challenges. So please know that we're quite sensitive to even one extra field and how much discussion that's going to entail. So we
want to help you all. We do want to help you all.
Like the IRS. Thank you. You all are actually the core of this whole organization. You're the glue that keeps it all together. So thank you, all of you.
Very good. Well, thank you, Tracey, for bringing that up. Thank you, Dr. O'Brien and Dr. Tehrani. I think there's some exciting new projects in the work here. So we will keep this on the agenda for our next meetings for sure. Next on our agenda is a presentation from Chris Seitzma, who is a Vcsqi board member. Chris is the Director of Outcomes at Winchester Medical Center, and she is going to speak to us about how she uses data at Winchester. Chris, I'm going to pass it over.
Can you hear me? That's the first thing.
Yes, ma'am.
Oh, great. Okay, so Eddie, I need to go backward.
Okay.
Okay, all right, thank you. Okay, first of all, it is always an honor to speak to the Vcsqi and to represent Winchester Medical Center. And we're going to talk about how we use the data for quality initiatives. I have nothing to disclose. Before we go too far, oh, okay, Eddie, is that you? Okay, before we go too far, I just want to give a brief overview of how we govern or look over our Heart and Vascular Center. We do have a Heart and Vascular Oversight Committee, and under there are 5 councils. The Valvular Heart Disease Council is surgical and non-surgical valves.
The coronary heart disease council is very challenging because it covers cardiac surgery, invasive, non-invasive cardiology, and the chest pain center. We have an EP that covers our ICDs, our Watchmans, and our AFib ablation, congestive heart failure, and then the Peripheral Vascular Disease Council actually has 11 procedural databases that the Society of Vascular Surgery has set up. So that's a real challenging area for us to look at as well. You can see each council has a medical director, and there are some that have co-surgical directors. And at the bottom in the highlights, you will see that outcomes reports at every one of these councils, which meets quarterly. When we report to the council, we do report on the strengths, and we try to report on opportunities. The full data pack is tried to give to the members the Wednesday before the meeting, and so at the meeting we do focused review. So we're going to look first at how we used Vcsqi in cardiac surgery, which was the bread and butter of the Vcsqi for a long time, and in the pursuit of the 3-star. The contributions of the Vcsqi to me. We were at first, everyone was kind of looking at the STS benchmarks, and that is a 50th percentile, so that's kind of like mediocre. So if you're pursuing a 3-star, you can't settle for the STS median. So early on, I asked the Vcsqi and Eddie to give me 85th and 90th percentiles in many categories. Now in the STS report, those are available for the NQF, but there's a lot of measures besides NQF that we were interested in. For example, reintubation, readmissions, blood use, and readmits to the ICU. And very interestingly, and early on, we established the Vcsqi as best practices. And now, anytime we give out some information, the question is always WWVS. What would the Vcsqi say? So this is what happened to me in 2011. I kind of took over these CAB indicators, and we were looking at them, and everything was available for the STS mean. But we had some information that we really wanted to glean to be best practice, and it was process and outcomes measures. Our H&Ps, for example, completed before PAT, an intra-op cardiac arrest, number of events, and very critical to us at this point was how many times were our MAPs in the OR less than 50 for 5 minutes. We were actually able to glean some of this from the 85th percentile and do our true benchmarking. And then you can see your standard outcomes are also there, and we had the information for the 85th percentile at this time. The other thing that Vcsqi does for us now is we benchmark not only in the state of Virginia, but Maryland, Michigan, and Washington. And this is just an example of a renal failure OE. Our renal failure OE, which has been pretty good. So what we are starting to look at here is, well, let's compare ourselves to others, not just ourselves with a Vcsqi, but if you look here, there is a group that have an OE greater than 1 of about 17%, and in Virginia, we were at 33%. So we see that there's definitely opportunities for us to look even in this one area of renal failure. So what happened with the Vcsqi is when they brought in cardiology, we saw a new measure, and that was the AKI, or the incidence of acute kidney injury. In the PCI database, that is a very, very tight definition. For example, it's an absolute increase of only 0.3 milligrams per dilutional unit, or an increase of 50%, or the new requirement for dialysis. So when we put up the AKI and looked at CAB onlys, we can see that the incidence of AKI might be alarming in many areas, because even though you don't have full-blown renal failure, AKI is known to then, when you have a subsequent readmission, be a challenge in the creatinine level. So the patients can have a worse outcome just by the nature of the AKI. This was an interesting thing, because as soon as I have a question from my group and they ask me about what Vcsqi say, and I send it to Eddie, I usually have an answer, if not that day, within the next 24 hours. So my question from the PA was, okay, what about AKI and looking at intra-op transfusions? So in this area, you can see at the top, if there's no intra-op blood transfusion, where your AKI is, and if there is an intra-op blood transfusion, the level of the AKI. And you can certainly see, here's the Vcsqi, 24% AKI with no intra-op blood, any transfusion at all went up to 37%. This was even more telling in the post-op transfusion level, because if you just take a look across the board here, only one time is the AKI incidence greater than 40% in any of our Vcsqi members. But if you add any post-op transfusion, you can see greater than 50% in about 5 of those areas, and interestingly enough, greater than 30% in every single incident. So again, looking here, you see the 21% for no post-op blood, 43% for any post-op blood products. So, okay, how do you sell Vcsqi participation? Because it doesn't come free. Of course, there is a cost. And how we sell it is we continually bring to the forefront that you have a collegial relationship with actually premier programs in the state. You have the opportunity to unblind data and look for best practice. You can track things over time. And I want to shout out to Mary Washington. We had a site visit there to look at the readmission rates, and we got so much useful information. And the other thing is you actually have on-site availability. The Vcsqi team will come to you and do presentations. And for us, the area that we're continuing to be challenged was in post-op blood use. And the Vcsqi came, and we had anesthesia, cardiac surgery, and many clinicians represented. So here's what Mary Washington helped us with. As you can see, the STS readmission rate's about 10%. In 15, we were kind of like, what are we doing here? We need some help. So we did get some information, and we do an improvement, but we said, could we do better? Mary Washington gave us the idea about the red armbands. We instituted that. We instituted patients calling the office before coming to the ED, and we instituted talking to referring physicians and referring practices that they should call cardiac surgery if they have a question. And as you can see, for 2019, our readmission rate for cab only was 4.6%, and this is the 90th percentile. So we were very happy with that, of course. So what else happens? We have best practice opportunities. The first thing we looked at for the Vcsqi was atrial fib prophylaxis. At this time, both our AFib and our stroke rates were actually concerning. So since we have looked at the protocols and enacted amiodarone preoperatively, our rate has been less than STS since 2016, and right now we're rivaling the 90th percentile in both AFib and stroke rate. There's the, again, the Vcsqi can show you the incidence of AFib across the continuum of all the hospitals, giving you also the Vcsqi and the STS benchmark. Most areas, the Vcsqi benchmark is better than the STS mean. There was another best practice opportunity, that at early extubation. This was a little bit of a hard sell to some of our clinicians at the hospital because they said, what's so magical about 6 hours? Why aren't you looking at 8 hours? Why aren't you looking at 10 hours? In reality, the length of stay for the ICU in days is not going to be any different. You're still not going to transfer them out that morning. But we had to explain that indeed, there is a decrease in length of stay in the ICU hours. And something that is less tangible, but you can certainly see, is the increase in patient and family satisfaction. Just imagine if your family member had open heart surgery and the evening, the very first time you saw them, they're sitting up, they're able to talk to you, and they may even be sipping on some water. That satisfaction alone has been something that the nurses have seen, and respiratory therapists. It's just a really good warm feeling. But of course, there was some concern. Number one, was there going to be an increase in aspiration pneumonia? We do put everybody on the SBT, the spontaneous breathing trial, and at this rate, we are continuing to watch our pneumonias, but it has not been an issue. This is, again, the data by the Vcsqi, and this is kind of cool because in some areas now they're actually dividing it up into areas that are low volume, middle volume, or medium volume, and high volume categories. And giving this information to our physicians is even better to take a look at apples to apples in the Vcsqi. And here definitely you see the Vcsqi outperforms the STS median. Another best practice, and this is one we continue to work with, is blood use. And when we looked at our blood use and we were trying to work on some intra-op and post-op blood use, one of the questions that we came up with, are we accurately assessing our patients for blood transfusion? are we looking at the patient triggers like symptomatic, or are we truly just looking at H&H triggers? So we started to really take a look at every patient that got post-op blood transfusion. And about this time, my question for Eddie was, well, actually it came from our committee meeting, you know, if our patients are getting blood, if we're adequately assessing them, how many of them are actually just getting 1 unit? And this was post-op RBC's breakdown of units transfused, isolated CABs 17/19. This is the area for only 1 unit. And actually it was at almost 70% in 2017 of our patients that got blood were only getting 1 unit. We have steadily seen a decrease down to 50% in 2019, and Eddie actually just released us some newest data this morning, which was 17%. Hard to believe where we were and where we've come. Now comes the advent of cardiology into the picture, and this is so exciting for us, especially myself, who covers all the cardiac databases. What you're now able to see is marrying the outcomes across the continuum. You have statewide comparisons again. You can do quality initiatives, and you have real-time feedback. And by real-time feedback, I mean as soon as we get the data uploaded, we can actually go in there and have Eddie help us pull out the outcomes. The first thing that was looked at by the Vcsqi was vascular access site by hospitals, straight PCIs, no cabbage, and again, the ability to look at the volumes of these patients, of the sites, is very encouraging to us, because we can see in the high volume sites, which is greater than 500 PCs a year, there are still some areas where greater than 50% of their accesses are femorals. When we first started to look at this, and our physicians were saying, you know, well, I'm very comfortable with the femorals. I do very well with the femorals. Why should I switch? As you can see, though, we actually got to switch pretty soon into radials being a large percentage of our patients, STEMIs as well as regular PCIs. The reason it made a difference, and the reason we were encouraged to see this, is the Vcsqi actually looked at 4 outcomes comparing femoral and radial access: bleeding event, blood transfusion, length of stay, and mortality in the cath lab. In those 4 indicators, there was all statistically significant differences between femoral and radial access. Another area that we've already kind of alluded to a little bit is the acute kidney injury. And this is PCI versus CABs by hospital. The one indicator here in the middle, this PCI plus CAB, for us is a very low volume, and usually these are patients that have an emergency procedure. So we really look more at your straight PCIs and your isolated CABs. And again, you can see the incidence of acute kidney injury varies significantly in these hospitals. And again, Vcsqi is able to show us by hospitals, by volumes, femoral versus radial AKI. The last area I just want to touch briefly on is our ability to have research. We actually have access in the Vcsqi to major centers. There's a research and writing committee which is very active. You have opportunities to talk with biostatisticians, and you can have research presentations at the quarterly meetings. This has become one of my favorite areas of this meeting now. And currently we are looking at an amiodarone in obesity study. We have a relationship with Shenandoah University Pharmacy Schools, and oftentimes residents need research projects. So what we did is looked at amiodarone because we're very interested in our AFib rates, and we understood that amiodarone is known to be lipophilic. So our question was, does the amiodarone stay in the cells longer in obese patients and thus higher AFib rates, or is it released over a longer period of time and lower AFib rates? So we're currently evaluating that, and we should be reporting this next month to the Vcsqi Research Committee. Thank you.
That was fabulous.
Thank you.
You should go on the road with that.
Okay, I accept enumerations for that.
Thank you. Any questions for Chris?
Yeah, Chris, this is Jeff Rich. That's a great presentation. 2 questions for you. One,
yes.
aspiration pneumonia after early extubation. You said it was great for families to see their family member drinking water. Water's the worst thing to give to somebody who's got compromised airways or compromised vocal cords, and swallowing mechanisms usually has to be thick liquids. I mean, I've gone through that with my mother. So have you changed your protocol for giving nutrition to those patients rather than just straight water? You know, would you give them liquids?
Any patient coming off the vent, do we do a 3-ounce water test? The swallowing test is done on all our patients. So I'm not sure. I guess when I say sipping water, I guess I meant sipping liquid. So I'm not sure exactly that water was the correct word, but they do use the 3-ounce water test now on all patients that come off the ventilator before they start them on any kind of nutrition.
And the other question related to radial versus femoral, and this is probably Robert Shor should talk to this more than I, but when at the Cleveland Clinic, we pushed our affiliate hospitals to go through radial. We had some hospitals who had, radial outpatient stuff where they'd actually sit in a reclining chair after the procedure and get to go home later.
Right.
I wonder what your thoughts are on that. I know there's a lot of opposition to radial versus femoral, and I know, and Robert can comment on this, that, anemia after a procedure is weirdly calculated by the ACC. I know you guys are doing a much better job in trying to figure that out, but, just a routine drop in hemoglobin, which could be related to hydration, is called bleeding. So, Robert, I'll let you take it over.
So I think you've raised a couple issues. Number one, I think there is a large push toward moving procedures to outpatient. And in order to do that, you need to go radial approach. And I think there is a growing acceptance of that. We've seen higher percentage, a good percentage in Vcsqi. The whole issue of bleeding and some of the metrics from NCDR is problematic. We have pushed back with the AKI 0.3 rise. Some institutions, the physicians have elected not to get a post-procedural H&H. So if you don't test it, you can't say that the number has dropped. Some people are getting drawing blood after they've been hydrated, right as you're sticking them for the procedure. Send some of that off as your baseline, so that acts as your baseline for pre-procedure. There's no perfect answer to this, but I think the bottom line is there's a growing move, and I think most of the younger operators are doing things radially. And I think if we can provide the opportunity, whether it's a learning experience for those folks that say they're more comfortable femoral to transition to radial, that would be beneficial. For those centers that have, for Chris, I mean, for those folks that said they're comfortable doing femoral and they're just fine with that, what did you do to transition them to radial?
It was a lot of one-on-one. In fact, peer pressure is sometimes some of the most effective way to do something. So we had some of our early performers with the radial approach. We showed their outcomes because we did have some issues with bleeding, as you know, too. The definition is always difficult, but we had we showed the research that showed that radial had earlier ambulation, earlier discharge from the hospital, and it just kind of became a wave from moving from femoral to radial. We just didn't see a lot of the resistance that we anticipated, and even moving to it in emergency PCIs, in primary PCI, we were able to transition to that very quickly by one-on-one physicians talking to each other.
Dr. Shor, I think you're muted here.
Thank you. Was there resistance for the older folks? Did they get sent off to be trained? As far as a learning curve for them, just from a practical standpoint, for other institutions to be able to transition those folks that are set on femoral.
I think the earlier adopters did have some training outside of the facility, but then once it became a wave in Winchester, then it was one-on-one, peer-to-peer. You have to understand we also don't have a whole lot of practices. We have one large practice and then one smaller practice. So within the practice, there was a lot of communication. You know, they're in the same office building, they share the same patients. The hardest transition was the STEMIs, the primary PCI, because of the concern about the increased time for the door to balloon. We did not see that, and so everybody was really encouraged by that. Because, of course, door to balloon is something that's a very big marker for us, and they were concerned that this was going to affect our door to balloon. It did not.
I think we're having trouble hearing you again, Dr. Shor.
I talk and then I put myself on mute. For those institutions that still are heavy femoral, you know, I'm sure Chris would love to have people chat with her about how they manage to transition, and it's a great opportunity. So I encourage that.
Wonderful. Thank you so much, Chris. It was a great talk. And we will continue moving forward on all fronts here.
Thank you.
Last but certainly not least, we have our very own Ms. Sherry White, our Quality Improvement Advisor. Sherry is tasked with the difficult proposition of providing a quick summary here on COVID-19 reopening and what Vcsqi programs and practices are doing to get back on our feet here. Sherry, I'll pass it over to you. And I believe there's some interactive segments here. So if you can stick with us for a few minutes here, that would be greatly appreciated to all of our attendees. But Sherry, take it away, please.
Sounds good. Thank you, everyone, and good evening. Hope all is well. The board is constantly looking for ways that we can increase value. And with the COVID-19 pandemic, you know, this is something that is very new for us all. We haven't experienced, and we wanted to figure out how can we be best use? How can we help during this pandemic and just help? So we sent out a poll to all of our members. We had a few responses, but I also found an article. So the basis of this discussion, we're going to focus it around an article that I found in a Forbes magazine recently, September 14th, of how the pandemic has upset healthcare. They list 4 problems, and then they give 5 potential solutions to fix it. So again, we're just going to focus the results of the survey around this article and have a brief conversation or interaction as it relates to this. Okay, so just diving in from looking at the survey, we asked our programs to rate their experience since reopening. You know, how much impact has it been for you? How difficult has it been? So for the 6 responses we received, this is the results. So for the maximizing the everyone who's participating in the call today, I want to re-poll the group. Let us know how COVID reopening has impacted you and your organization. So you should see a poll on your screen. Just indicate, have you had no impact? Has it been slightly difficult? Are you kind of neutral, moderate difficulty, or severe difficulties? So let us know where you are. Kind of stable. Okay, I'll share the results. Well, as you can see, there's no one who has not been affected by COVID. I'm very curious about the organization that is severely experiencing difficulties. So we're going to dive in a little bit deeper into the specific problems according to this article around COVID-19, and I'm looking forward to calling upon each of you just to get more information about how this really has affected you in healthcare. Okay, So the first problem that was pointed out is how COVID-19 has put hospitals and healthcare in a system of economic crisis. So according to the article, the American Hospital Association estimated about $50 billion a month in loss. A number of hospitals had closed in result to this crisis. And there has been downsizing of employees that resulted in over 1.3 million. So it truly impacted healthcare. And the ways that it impacted healthcare is the severe quarantine methods or measures, the stay-at-home orders, which canceled procedures, protocols put in place to kind of keep us safe and protecting us from the virus, which resulted in loss of income for our hospitals or revenue. And now with reopening, the mindset of our patients hasn't changed. They are scared to come back. So how do we fix that? How do we, what problems have you faced as it related to that? So I wanted to call on a few of you. What experiences have you felt or experienced related to COVID-19 in your organization with reopening? What protocols are you putting in place, or what have you experienced with bringing your patients back into the healthcare environment? Chris, I'm gonna call on you. Are you on mute? April Howell from UVA, are you still here? For the sake of time, I'll keep going because I'm conscious of it's getting late in the evening. So some of the issues that was brought forth from the survey was related to PPE. Have you experienced any issues? Some have not experienced any issues. Some are not totally sure. But most organizations have put specific sterilization processes in place because of the shortages that were present when the pandemic first hit. So as it stands right now, there seems to not be such an impact in patient or personal protective equipment at this time, but because of the parameters that have been put in place. But what about employees? What resources or protocols or tools have you put in place to kind of protect your employees from COVID-19 and just to make sure that the exposure is limited or contained? Based off of the survey, there's dedicated clinics for employees and even an employee hotline to assess symptoms. And based off of those symptoms, it will be indicated if the employee needs to go in for testing. There's a restriction on travel. And then there are some organizations that have dedicated entrances for their employees that are isolated from regular patient population. Is there anyone on a call who can indicate any other parameters or solutions they put in place to help protect their employees or staff?
Yes, Sherry, here at Mary Washington, I'm sure other hospitals did as well. We actually restricted visitation for a good while, and that has slowly been opened back up.
That's pretty cool. How about for surgeries? I know some most organizations limited the number of people that can come and sit for surgery, waiting rooms. That's another example, limiting it to one person or just having the patient dropped off and we call you.
They were dropped off.
Wow, thank you so much. Is there any other resources or tools you're putting in place or to help combat COVID for our employees or staff?
Well, in addition to having restricted entrances, we're also having every single person who enters and exits, or anybody that enters our buildings has to have a temperature check. And I figure that that's the case throughout all facilities.
Very good, thank you. And also one of the residual effects of COVID had to do with childcare. A lot of childcare centers were closed. There are some hospitals that had put certain resources and made it available to their staff that offered childcare. Inova is one of them. Is there anyone from Inova on the line?
Sherry, this is Liza from Inova. I'm here.
Okay. Can you tell us more about the childcare practices that you're putting to help your staff?
I don't have any children myself, but I work in the operating room, and a lot of the nurses there all have children. So it was something that they talked about a lot, and I know Inova was allowing, refunds or giving credits back to people to give them their, the money back from not having the childcare. And I just wanted to go on record as saying that Inova really, I feel like, has done a whole lot of good to protect all of us. We've read horror stories online about people who didn't have any PPE, and we have a lot of traveling nurses in our operating room who had been on assignments where they didn't have any negative pressure rooms, they didn't have N95 masks, they didn't have anything. And I guess wanted to take the opportunity to say that Inova, I feel like, went above and beyond to make sure that I personally, obviously Dr. Spear could speak to the behind the scenes part, but as an employee, we never felt like we wanted for anything as far as masks and PPE and anything else that we were needing. They gave us time off when we were all not operating. They even designated special time that we would, if we were sent home without pay because there was nothing to do, people weren't taking it out of their PTO budgets. It was a different allotment of pay that you could use rather than burning through your vacation time on the times that we were slow. Or they would send everyone to other units if they wanted that option to try to help out and work. A lot of our nurses went and cross-trained in proning. We had like a little proning team that would go to the ICUs and everything and help them prone patients when we had a lot of patients that were needing to be flipped back and forth because it's a very labor-intensive process. So we had a few champions in the operating room that really became specialists in that, and then went to a lot of the units to help the bedside nurses prone patients. So they really did a lot to try to train the operating room nurses up as much as they could to disperse them to help where they could when the ICUs were overloaded. So just
pretty cool. Thank you for sharing, and kudos to Inova. Thank you.
One of the biggest things they did, I think, at the beginning of the pandemic was we had 118 critical care beds, and about 10 of them were negative pressure. So they over the course of a month had negative pressure in all the ICUs. So the safety and the ability to then give the aggressive respiratory care, all aerosol generating, was much safer. And we had at most, although we had about 400 ventilators that were available, we only had 53 at the max on ventilators, which was a much different statistic than other places. So that recognition made a big deal.
Thank you. So according to the article, problem number 2 is that COVID-19 caused patients to delay procedures, which ultimately resulted in more fatalities. Increased side effects because of the severe, I think the scare that the media, everyone put on COVID-19, and we really weren't prepared for this. It put everyone in a state of fear. And everyone still has that fear, and that fear was still greater than your own medical treatment, if you will. So more that if someone had chronic heart conditions, they probably put that off because they were more fearful that COVID-19 would end their life before their heart conditions. So this was another residual effect. And, Eddie showed some slides earlier as it relates to the dip and then the bump and the spike. And it could be because of this, it's just getting worse because of not going to the doctor. So can anyone speak to this? Have you seen anything in your environments that has spoken to this? I know we all see it, but do you have any examples that you wanted to share with us? Procedure delays?
We had a 50% reduction in ST elevation MIs and dissections that were seen. It's estimated that 1 out of 4 patients with a cardiac condition did not seek care. We had 4 post-infarct VSDs in over about 10 weeks. We haven't seen that for years, probably 1 in about 15 years. So we had 4. 2 papillary muscle ruptures as a post-infarct mitral valve problems. So it turned the clock back by 20 years with the delays in seeking therapy.
Wow. Yeah, something.
Yeah, I concur completely. We've seen a lot of late presentation stuff, or people that arrest at home, and then they're part of the statistics of death.
That.
So Robert and Ellen, do you think that's related to patient fear or maybe provider reluctance?
Yes.
Both. I agree completely. There was one situation, one of my partners told me, and again, this is anecdotal, this is one case, but EMS was called to a guy who was complaining of some chest pain, and EMS, not wanting to take him in the throes of early COVID to the hospital, said, it sounds like it's indigestion. He happened to be a personal friend of one of my partners who went over to his office where he was having the symptoms. They took him over to the hospital. He was having a STEMI and he ended up getting intervened on. So yeah, there is reluctance on providers as well as the patients.
Jeff, it's still being translated into the patients who are coming now. Our length of stay, both in the ICU and the post-op length of stay, has increased because the EFs are lower, and the number of patients requiring a sort of coronary bypass surgery is much different. It's much higher than our previous rates. And I was on an international call today, and that's been the shared experience around the world, is the number of patients coming in that need coronary bypass, and that they're all staying in the hospital longer, their EFs are lower. So it's sort of that sequelae. If they didn't have fatal problems or major morbid problems, they still had significant insults.
So do you think the number of left ventricular assist devices or temporary LVADs, temporary left ventricular support, has gone up as a result for late patient?
I don't know. With us, we have a relevant volume with transplants and VADs anyway, and I haven't seen that change just because of how aggressive the heart failure component is in our center. That's a real priority. So I don't want to give misleading information.
So problem number 3 has to do with delayed pathology labs, which increase the patient risks. So on average, there's over 831,000 tests for COVID being ran every day. And because the priority are for COVID testing, the other labs or pathologies that are necessary are being delayed, which also results in delayed services, delayed treatment, and increasing the risk of our patients. So as it relates to COVID testing for patients, when surveying our members, everyone seems to be screening their patients upon entrance or even prior to procedures, and doing either on-site testing that are resulted in a few hours or within 24 hours. Okay, so diving into a little bit more as far as procedures. So again, they're testing them upon admission. There's dedicated facilities for testing, drive-up testings, and there's a few that had 3-day turnaround. An assessment for
Do people think that they're having adequate testing and rapid enough testing?
Hey, this is Jeff. No, I went to go get tested after my mother died from COVID-19, and it took 10 days to get my result. Literally 10 days.
Can we do a roll call for whoever's on the line still, each facility? How long does it take for testing to come back from your facility? So I think the Winchester they had a 5-hour rapid testing and a 3-day turnaround. Winchester, is anyone from Winchester on the line?
Yes, Sherry, this is Chris. I'm having trouble muting and unmuting. I'm not trying to avoid you. I'm sorry. Yes, we actually now have a 1-hour turnaround time available as well. So our doctor, our Vice President of Medical Staff Affairs gives a COVID update every other Wednesday for about an hour and a half. It's usually attended by over 100 people. And so that's when we get all the information of what's available, how we're working things. It's been a very organized effort. And like I said, we now do have a 1-hour test turnaround if need be.
Right, and this is Jeff Rich. That's for inpatients, correct?
Correct.
Yeah, if you're an outpatient like I was, it's not 1 hour or 2 hours, it's 10 days.
I don't know of any that we've had as 10 days. I think our longest has been 5, and mostly it's coming from the Quest lab. It had been 72 hours.
This is Alan Spear. I think we've got a limited number of the hours turnaround that is allocated by facilities per week. We do have for all the pre-op patients, it's 48 to 72 hours. And I would agree with Dr. Rich that although Quest says that the turnaround time can be to 3 to 5 days, it's not infrequent that it can vary between 8 to 10 days. Wow. It's not at all consistent, and testing still remains a challenge.
So let's progress for the sake of time. I'm sorry for this. So problem number 4 that has resulted in the article, COVID-19 is the only health concern that is receiving attention across the media and the government and utilizing all the resources. So this also is a circle type of effect because this COVID-19 is has so much attention in the media. It also adds to the fear of our patient, which creates this obstacle that we're facing, just a revolving circle because it doesn't solve it. Okay. So as it relates to this, we polled our members just to ask them how far behind were they with their cases since pre-COVID. So the cardiac surgery groups says about even, 10 cases a month. Some areas are already caught up, some are 10%, and some are about 30 days behind. So we're a little all over the place as it relates to this, but we're still trying to catch up. Okay, so what about cancellations due to positive testing? How many patients have been canceled or procedures have been canceled across your service line as it relates to positive testing, and how has that impacted your treatment in your service? So I want to do another poll if we can. Just let me know about what % of your cases have been canceled due to positive COVID testing. And I'll share the results. Okay, so majority is less than 10%, and there's a few that's between 10 and 25 and 25 to 50%. Okay, so what about your staff? One of the things that has happened, that we hear it a lot here in Cleveland, is whenever your physicians, your nurses, your techs are exposed to COVID-19, what protocols do you have in place when your employees or your staff are infected by COVID? And how does this affect your overall procedures, what do you have to do? You know, do you contact the patients that have been exposed or introduced to the person that was exposed? What are your protocols that you have in place? So I just want to call on a few. Mike from Mary Washington, do you have any protocols or processes in place?
Fortunately, and your question's in regard to associates who do test positive, is that correct? Sherry?
Yes.
So we only had one associate test positive, and that person actually was a traveler, not a traveler, but a contractor who was one of our surgical assistants, and fortunately was at our hospital about 3 weeks prior to testing positive. And so, you know, that person ended up having to quarantine. It was relatively early on during COVID. And when they were requiring associates to retest prior to reentry in the workforce, and unfortunately, I think depending on the type of test they got and the sensitivity, there was always that risk that they would test positive. And this person actually tested positive, I think 3 times after his initial exposure, and it took a while for him to get back to work. But otherwise, we really didn't have any other. Positive tests, and didn't have to deal with the issue. As far as our policy, hospital's policy, you know, associates were required to quarantine once they got sick, and then they had to report back to employee health before they could come back into the workplace. And I do believe they were required to test prior to. That was early on, but I don't think they are retested now before re-entering the workforce. Fortunately, I have to say, I've been listening to all the comments about, you know, what individual hospitals have done to support their associates, and I have to agree with some of the folks who talked about their institutions. Mary Washington was so supportive of their associates during the whole crisis. You know, we were fortunate in cardiac surgery. We slowed down just doing like everybody else, urgent and emergent cases, and our volume was really low in April and better part of May. And so a lot of our staff really kind of hunkered down. The hospital was very supportive, and there were some folks who, you know, needed to get their hours in, and they provided opportunities for them, you know, to get their hours, but others used their personal time off. The hospital also provided a bank of personal time off for people to use. And, you know, they were just super supportive of it. So in those units where, you know, we were taking care of COVID patients, you know, we did have a number of associates test positive, but quite honestly, I'm pretty proud of it. Our positive COVID testing among associates, especially those who were in those high-risk areas, was very low. And I think Mary Washington was just very aggressive. They were a lot of times things were changing daily, but that's probably because of their vigilance. Yeah, that's my 2 cents.
Hopefully just as an information thing, there is the Virginia app COVID Wise, so that if you enter and someone and you have an exposure, or someone else knows that you've been exposed, you'll get a notification. So that's separate from what any institution or system does, but COVID Wise is an app from the state that you can use to help identify people that have been exposed.
Sure. Okay, so in looking at the article, they gave 5 solutions to try to improve the situation as it relates to COVID-19. The first one is to utilize telehealth. Distance, still deliver care, but do it virtually. I know Winchester, Chris, if you're still on the line, I know according to the survey, Winchester is utilizing telehealth. How can you do this? How has that been successful in a cardiac environment? And what type of visits are utilized for telehealth?
It has been successful a lot in, of course, primary care and the urgent care.
It's not successful, of course, in emergent patients. We're still telling them they need to come to the emergency room to be seen. So that, they actually are predicting that now, the way that it has worked for us, we're going to do even more telehealth in the future. It's kind of going to become the norm instead of the exception.
That's totally true. We have several hospitals here in Cleveland who are just changing over primarily 60% telehealth, even for cardiac. Hasn't been successful, but they're trying.
Jerry, this is Mike. If you don't mind, I'd like to add about our experience with telehealth. I was pretty concerned just about our readmission rate during that time period. But I have to say that our readmission rate dropped during that time period. And I think a lot of it had to do with just a lot of the, we had a pretty robust follow-up process in place using, I don't want to say telehealth, but just using phone call follow-up and surveillance after discharge. And so our advanced practitioners did an amazing job during that time period, because as most people would agree, when we were talking earlier about, blood use and why blood use was up, that patient population during the COVID months was a much higher risk of patient or population. And the fact that our readmission rate dropped during that time, I thought was reflective of the work the advanced practitioners did, and our nurse navigator, our entire office staff, our office nurse, just, staying on top of communicating what were those concerns before they were discharged, and making sure there was that continuum of care, and with those people who were involved in that surveillance and follow-up process. So we'll continue to use it, that's for certain.
Definitely. Does anyone else want to share their telehealth experience and how they're using it?
The one item I would add is one of reimbursement from insurance companies. With COVID, there was a relaxation both from CMS and insurance companies. This is gone under tremendous scrutiny, and where it ends up and what shape it takes is unclear. We all felt like the genie was out of the bottle, and it was really great for many of our patients who travel or have difficulty coming in. But where there's money attached to it, whether and how much you get reimbursed in the future is not clear.
Diane from Johns Hopkins. Would you like to share anything? Are you utilizing telehealth by chance there?
Yes, so we have did a tremendous turnaround. There's like across the whole Johns Hopkins, this is like 40,000 televisits. And so we actually had to upgrade our televisit system to accommodate it, but we definitely have moved off to televisits, and actually it's increased the number of visits. So our our cardiac surgeons and our nurse practitioners are reaching out and keeping closer contact, more frequent contact with our patients.
Thank you for sharing. Okay, so this next remedy for COVID-19, according to the article, is hospital bailouts. There's been a number of hospitals, private practices, that actually had to close due to the decline of patient care because patients weren't coming into the hospital. So we surveyed our members and just asked what was their financial impact due to COVID. There was some who wasn't quite sure. Some indicated that there was profound impact, but it's getting better since reopening. There's been millions of revenue lost in the past 2 months, or April and May. A significant financial shortfall, and of course, there's just been millions of revenue loss across the states. Okay, we also asked how many employees, or did your organization have to furlough employees? And of the 6 participants in the survey, it was 100% across the board. Everyone had to furlough employees. And we also asked about the CARES Act, which was a tool, or financial benefit for healthcare organizations to help them due to the COVID-19 pandemic. There were 2 organizations that did not answer the question, but then the other 4 did participate in the CARES Act. So as it relates to going back to the 5 things that they recommend would help remedy COVID-19, the third one is transmit digital data. So utilize your EMR to send medical records electronically versus having the patient hand carry, that it helps to lessen the exposure. So just utilize technology more to transmit data. Number 4 is explore alternative forms of insurance for the younger population. So the article spoke about GoodRx, which is typically a medical company or insurance for medications. But they also have a line for healthcare treatment where they're doing telehealth visits primarily for general medicine. So if you have a cough, a headache, the younger generation tend to use GoodRx because it's less costly. So this is one solution indicated. And the next is to use academic standards to evaluate best practice, elevate best practice. So this just means continue to do your best in upholding patient care, holding patients accountable, reaching out to them just to help them to remember how healthcare is important in their lives. Okay. We also surveyed our respondents and just to find out what other strategies or tools have they put in effect to help combat the residual effects of COVID. So again, we have telehealth, we have furlough, restrictions on travel, restrictions on patients coming into the hospital, and then biweekly updates, just keeping everyone informed. Okay, so I just open the floor up for anyone else who wanted to share. Are there any other strategies that your organization is utilizing to combat the residual effect of COVID since reopening?
One comment I would just make is that from an outpatient practice, we have or are approaching pre-COVID testing volumes, office patients. What we're finding though is the volumes in the hospital are lagging behind the pre-COVID. So we're still finding people who are reluctant to go in, and certainly fewer, it seems like, elective procedures. And I don't know what other institutions are seeing as far as their inpatient non-COVID volumes, but that's been certainly my sense.
Thank you, Dr. Shor. Does anyone have anything else to add? I appreciate your time and staying the evening with us. And Dr. Shor, I'll turn this over to you for any closing remarks.
Thank you. I know it's late. I just want to thank everybody. Everybody's participation in all of these multiple efforts that we're engaging is really fruitful and beneficial. I missed the very first part. I had some technical issues. And I know one of the things we talked about from the board level was embracing the notion of diversity and inclusion and understanding the social determinants of care and disparities of care. And so we look forward to pursuing that in our mission of providing quality and cost-effective patient-centered care. So with that, I would just say thank you very much. Thank you for your time and have a great day. Be safe.
Thank you, everyone. Thanks for hanging on overtime with us, and take care. Be well. We'll hope to see everybody virtually in December.